Good morning, everyone, and welcome to the session organized by Center for Living Organ Donation today that is titled Access to Liver Transplantation. I'm very fortunate to have along today with me a panel of experts who are going to talk on various aspects of access in terms of ethnicity to organ donation. My name is Nazia Selzner. I am the medical director of the Live Donor Program at TGH, and I'm moderating this session today. I'm going to introduce one by one in more details all our speakers this morning, but very briefly along with me, I have Dr. Jennifer Fleming from Kingston, Queen's University. I have Dr. Natasha Chandok from University of Western Ontario, who is currently working in Brampton. And I have Colleen O'Yin from the Toronto Center from Liver Disease. Today's session is being recorded and will be available in the Center for Living Organ Donation's YouTube channel. And everyone is welcome to send their question along using the Slido. So here, without further ado, we are going to start our session today. Our first speaker is going to be Dr. Jennifer Fleming. She's going to talk on the burden of cirrhosis in Ontario. Dr. Fleming is a transplant hepatologist and a hepatologist. She is the associate professor of medicine at Queen's University. She has a long-standing and focused research on the epidemiology and natural history of liver cirrhosis, including hepatitis C and primary liver cancers. And she's going to walk us through her presentation today, which is the burden of cirrhosis in Ontario. Jennifer, welcome, and thanks for joining us.
Thank you, Nazia, and thank you to everyone who's joined in on this webinar today. And what I'm going to be talking about today is aspects related to the burden of cirrhosis in Ontario. So the objectives that I have for my talk are, first, I'm going to review some of the basics about cirrhosis, just to make sure everybody is familiar with the condition. Next, I'm going to be talking about some work that we have done in Ontario, looking at the current and the future epidemiology of cirrhosis. And then to finish the talk, I'm going to be showing some preliminary data that we have, looking at the contribution of both immigrant and refugee populations to cirrhosis epidemiology in Ontario. So to start, I just wanted to review for the audience, what is cirrhosis? So cirrhosis is the final common pathway of multiple different chronic liver diseases. On the left-hand side here, this is a normal appearing liver without any scarring or chronic damage to it. What happens in the development of cirrhosis in an individual who has a chronic liver disease? Over many years, there's ongoing insult and inflammation that occurs within the liver. And the reaction that the liver has to that is to try and repair itself and regenerate the liver. But in the process of doing that, what can happen is scar tissue, or what we call fibrosis, starts to develop within the liver. And therefore, when this process goes on over a span of 10 to 20 years, a proportion of individuals who have chronic liver disease will go on to develop cirrhosis or end-stage fibrosis of the liver. When we as physicians and healthcare providers define cirrhosis, it's really based on what we would see under the microscope in an individual where we've done a liver biopsy. And this is just to highlight that in a normal liver, which is here on the left-hand side, if we took a piece of the liver and looked at it under the microscope, you can see that there's many cells of the liver that make up its structure, but there's not a lot of blue material here. What happens when you start to develop fibrosis or scarring of the liver, as you see here, there's the development of this blue material within the liver parenchyma, and that's scar tissue that develops. So when we talk about staging a chronic liver disease, we're really talking about how much scarring has developed in the liver over time. And what the definition of cirrhosis is when you take a biopsy of the liver and you see that there begins to develop these circular bands of scar tissue within the liver. That by definition is cirrhosis. And as mentioned, this usually occurs asymptomatically, or people may be unaware that they're having a chronic liver disease because it doesn't make them feel unwell. But this can occur over 10 to 30 years, and as mentioned, in a proportion of individuals, they will go on to develop end-stage scarring or liver cirrhosis. These are the most common causes of cirrhosis in the North American population. Historically, we always thought that hepatitis C was the most common cause of liver disease, but now it's become clear that non-alcoholic fatty liver disease, or NAFLD, is the most common cause of chronic liver disease and cirrhosis in our population, followed by alcohol-related disease, hepatitis C, and hepatitis B, with these conditions making up approximately 80% of all causes of chronic liver disease. However, there's other conditions that we see. There's autoimmune conditions such as autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis, as well as other hereditary conditions such as hereditary hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency, and then other more rare causes. But in the majority of individuals who we would see within a liver clinic, 80% of them will have one of these top 4 causes of cirrhosis. Now, when we diagnose somebody with cirrhosis, there's a spectrum of disease. A lot of individuals will be diagnosed in the compensated phase, which is clinically silent without symptoms. And if you have cirrhosis without any complications, the average survival in these individuals can be between 10 to 12 years. However, once you enter what we call a decompensated phase, or a phase where there are signs of liver failure that start to develop in somebody with cirrhosis, this really increases individuals' risk of death and dying, with the average survival in individuals with decompensated cirrhosis at less than 3 years on average. This slide is just showing what we would typically see in the natural history of chronic liver diseases. An individual has a chronic liver disease and over time may develop compensated cirrhosis. And then there's a risk, once you have compensated cirrhosis, that you will progress to decompensated cirrhosis. And this occurs on average in about 5% of individuals per year. So if you took 100 individuals with compensated cirrhosis, approximately 5 of them every year would develop a decompensation event. And the decompensation events that we most commonly see can either be variceal hemorrhage or bleeding from esophageal varices, the development of ascites or fluid in the belly, encephalopathy, which is related to confusion. Individuals are at risk of hepatocellular carcinoma, which is a primary liver cancer, or hepatorenal syndrome, which relates to kidney failure. However, interestingly, in individuals with decompensated cirrhosis, there's also a chance that this decompensation could improve if you're able to treat the underlying chronic liver disease, which is driving these decompensation. That includes alcohol abstinence in patients with alcohol-related liver disease. Treatment of both chronic hepatitis B and C can improve individuals' liver function, as well as the use of steroids for things such as autoimmune hepatitis. And so this is not a one-way path. Individuals can cycle through going through stages of both compensated and decompensated cirrhosis during the natural history. However, once you do develop decompensated cirrhosis, that's when your risk of death really increases. The analogy that I like to use when I'm teaching medical learners or patients about cirrhosis is I use the analogy that if you have compensated cirrhosis, it's like you have a 20 or 30-year-old car. It's not like a brand new one off the lot. It's a little bit rusty. The interior may not be as nice as the other ones. But as long as the car is still driving on the road, you don't necessarily need to trade it in. However, you need to take care of it. You need to bring it in for its oil checks and for its annual rust check in order to keep it in tip-top condition. But what can happen with these old cars, or in an individual with compensated cirrhosis, you can develop a decompensation event. And that's really when the wheels fall off. And then the question is, are we able to repair the car and get it back on the road and keep it functioning? Or is it time that we need to think about a liver transplant and trading in your old car for a brand new one? So I'm going to be switching gears now to talk about why understanding trends in both the current and future cirrhosis epidemiology is important. And just to clarify, epidemiology relates to disease trends over time within a certain population. Well, there's many different reasons why this is important. First, understanding what's happening to the disease burden of cirrhosis helps to identify key exposures which lead to chronic liver disease within specific regions or in populations. This information can also help with education and development of strategies to identify chronic liver disease early in its course, where it may be modifiable and treatable. It also helps with the implementation of disease management programs and therapeutics for individuals who are identified with chronic liver disease. And specifically related to liver transplantation, understanding what's happening with cirrhosis epidemiology can help to assess for changes in prevention efforts and facilitate future healthcare resource planning, such as the need for liver transplantation. So how can we figure out who in Ontario is living with cirrhosis? As we're all aware, Ontario is a large province, which is home to over 14 million individuals. And so it'd be very difficult to go door to door and try and figure out who has underlying chronic liver disease to try and describe these trends in disease burden over time. So what my research team has been doing over the past number of years is using health services research to try and understand what's going on with cirrhosis epidemiology. And what health services research refers to is the use of large-scale population data on patient characteristics and healthcare use that helps us to describe patterns and uncover important associations that helps to generate research ideas or influence healthcare policy. So in order to conduct this work, I use the databases of ICES. So ICES is an independent nonprofit corporation within Ontario, and there's many different sites within Ontario, mostly at all academic centers, including University of Toronto, Queen's, where I'm from, Western, where Dr. Chandak is, McMaster, as well as Ottawa. And what the ICES databases encompass are data that's collected through routine clinical administration of Ontario's publicly funded healthcare system. So anytime any individual goes in Ontario who's covered under OHIP goes and uses healthcare resources within Ontario, this data is collected. The data that is contained in these databases includes information from physician services, such as visits to the outpatient clinics, the inpatient hospitalizations, as well as the emergency room. There's data from Cancer Care Ontario, the Ontario Drug Benefit Claims, which has information on medications dispensed, the Registered Persons Database, which gives us information on individuals' age, date of birth, and date of death, plus many other databases, which allows us to get a lot of information on a lot of individuals within Ontario. So this is how I like to portray how we do work within ICES. So these colored bottle caps represent multiple different pieces of information on multiple individuals within Ontario that is stored within these databases. And just looking at the data when on its own, it doesn't give you a lot of information. However, when you use health service research techniques and you understand how to look at the data and analyze it, you can transform this data into things that will give you nice patterns and pictures of what's happening within the population of Ontario. So what we did was we identified all individuals in Ontario who were diagnosed with cirrhosis between the year 2000 and 2017. And the purpose of this slide is just to show you the burden of disease with almost 160,000 individuals identified over this time period. And we were able to assign each individual a suspected cause of their chronic liver disease, which led to cirrhosis. Most commonly, we saw patients with NAFLD, as well as alcohol-related liver disease, and then viral hepatitis, autoimmune, and other diseases were grouped together. And importantly, as I'm going through, especially in the third part of my talk, there was a large proportion of individuals with cirrhosis as Ontario who were immigrants or refugees, representing 14% of the population. So as mentioned, we identified all of these individuals with cirrhosis in Ontario from 2000 to 2017, assigned them a cause of liver disease, and we also defined a birth cohort. This is important because the majority of the exposures that lead to chronic liver disease, such as alcohol-related disease, hepatitis, and non-alcoholic fatty liver disease, are influenced by external factors such as lifestyle and environmental exposures, which can change over time depending on when you were born. And therefore, you can uncover important epidemiologic trends based on external factors that may be influencing the number of individuals with cirrhosis. Then what we did is we used this information to describe what's been going on over the past 20 years. And then we wanted to predict what is going to happen to new cases of cirrhosis in Ontario up to the year 2040 to help with healthcare resource planning. The next number of slides, what I'm going to be doing is I'm going to be talking specifically about a cause of chronic liver disease leading to cirrhosis. And then I'm going to be talking about the burden of disease within these birth cohorts. So you'll see here on the y-axis here, I'll be talking about the incidence rate, and that is the number of new cases of cirrhosis within the population. Down here is the year. So these first line graphs will be showing what we calculated from 2000 until 2017. And then what we did is we've broken it down based on when an individual was born. So here in the blue are individuals born before 1928. In the red, between 1928 and 1945. The green shows the baby boomer birth cohort between 1945 and 1964. The orange shows Generation X, 1965 to 1980, and then the light gray shows those individuals born after 1980 or the millennial generation. So this first slide is looking at individuals with NAFLD cirrhosis. So these are new cases that were observed within Ontario between 2000 and 2017. And you can see that within all age groups, the number of individuals diagnosed with cirrhosis went up over time. The average increase per year was 3.3% overall. And the highest increase in new cases of NAFLD cirrhosis were actually seen for females within the baby boomer birth cohort, where the number of new cases increased by almost 9% per year. Then when we look at projecting using these estimates and saying, okay, well, what will we expect over the next 20 years if nothing happens within our population? The number of individuals with newly diagnosed NAFLD cirrhosis is expected to increase by another 24%, and this will be going up in all birth cohorts. The highest increase we expect to be for women within Generation X, born between 1965 and 1980, and we estimate that the burden of disease within these individuals is going to increase by almost 350% over the next 20 years. So next, I'm going to switch to looking at alcohol-related cirrhosis. Again, we've broken this down by birth cohort, and these are what we've seen between 2000 and 2017. And though overall, the number of new cases declined by minus 1.2% over the study period, you can see that this is different based on when you were born. Whereas there was a decline in older birth cohorts represented by the red and the blue, and a stabilization in the baby boomer birth cohort, you can see that within younger generations, the number of new cases of alcohol-related cirrhosis increased over the study period. And the greatest increase was seen for individuals who were born after 1980, so millennials. So these are young individuals, and the increase in the rate of cirrhosis was almost 12% per year in this group. When projecting what's going to happen over the next 20 years, there's going to be an overall increase in alcohol-related cirrhosis by 15%, mostly driven by these younger individuals. And when we looked at specific subgroups, in the millennial birth cohort, in males born after 1980, it's expected it will increase by over 400% for men and over 300% for females. Now looking at hepatitis C related cirrhosis. So this is a viral hepatitis where recently we've been able to offer curative, well-tolerated treatments for individuals. Although over the past 20 years, there's been an increase in HCV-related cirrhosis by 4.1% per year. You can see that the greatest increase was within the baby boomer birth cohort, which is not unexpected, as this is where the highest prevalence of hepatitis C is. But you can see here, after the approval and access to well-tolerated, effective antivirals, which are able to cure hepatitis C, we're starting to see a decline in new cases of HCV-related cirrhosis within this birth cohort. However, interestingly, we've also seen an increase of HCV-related cirrhosis in younger birth cohorts, which we hypothesize is likely reflective of the ongoing opioid epidemic within North America, as that is a common route of infection of chronic hepatitis C. And again, concerningly about these younger individuals and men born after 1980, rates of HCV cirrhosis increased highest at approximately 10% per year. Projecting over the next 20 years, fortunately, there's an expected decline overall in new cases of HCV-related cirrhosis by almost 50%. However, again, if you look at different age groups, in those individuals born after 1980, there's a projected ongoing increase of new cases that will be seen over the next 40 years. Therefore, although we've made a lot of progress with hepatitis C, there are still efforts that are going to need to be focused, especially on younger individuals, if we are going to reach the WHO target for HCV elimination by the year 2030. Now switching to chronic hepatitis B, again, chronic hepatitis B is a chronic viral infection where we have lots of effective treatments that can alter the natural history of the disease. And you can see over the study period, there was a large increase in new cases of HBV-related cirrhosis in most birth cohorts up to the year 2010. Followed by a relatively steep decline. So although we calculated that the rate was overall stable, that this changed over time. Now, the reason for this, we hypothesize, is that the approval of antivirals within Ontario, which are highly effective, occurred in approximately 2009. And these antivirals have been shown to prevent disease progression. And so it coincides with a large, rapid decline after the approvals of these medications. The other thing that I find is interesting is that within the millennials, within the gray here, the line was relatively flat compared to all other birth cohorts where it went up and down. And this is just a reminder that the millennial birth cohort is the first birth cohort who would have been exposed to vaccinations for chronic hepatitis B at birth. And so this really suggests that this vaccination program has had a large impact on individuals developing hepatitis B within Ontario. Projecting over the next 20 years, we would expect an ongoing decline in new cases of chronic hepatitis B, but you can also see that they're going to remain stable and they're not going to go down to zero. And therefore, although we're much better at treating hepatitis B and altering its natural history, given the burden of disease, there's going to be ongoing need for therapy for hepatitis B and potential transplantation. Finally, I won't spend too much time on this side. This is looking at autoimmune or other causes of cirrhosis. So these are causes of cirrhosis which aren't affected by environmental type exposures. And there was overall a general decline in new cases over the study period, which were stable or declining for all birth cohorts. And over the next 20 years, it's expected that it will again decline or be relatively stable with the null birth cohorts, which is what we would expect for a disease which is not influenced by any external factors. So looking at what we can expect by the year 2040, overall within Ontario, we expect that 75% of all new cases of cirrhosis are going to be secondary to non-alcoholic fatty liver disease, followed by the next most common will be alcohol-related disease. Hepatitis C will compromise approximately 6%, and hepatitis B and other hereditary conditions will be 2%. However, based on the information that we have, this is going to be differential based on when you were born. You can see that in older generations, NAFLD will predominate, and in younger generations, there's going to be a much larger contribution of alcohol-related disease within that population. So finally, switching gears a bit, it's important not only to recognize that disease burden is increasing within the Ontario population, but also trying to understand which specific subgroups are more affected by one disease or another in order to try and target education programs, screening, treatment, and access to transplantation. And therefore, an important group of individuals to evaluate are immigrants and refugees to Ontario. And that's because chronic liver disease is a problem worldwide. And due to the large immigrant and refugee population to Canada and Ontario specifically, it's important for us to understand what impact immigration is having on cirrhosis disease burden. So within these ICS databases that we use in order to look at this, we are able to link to the Immigration, Refugee, and Citizenship Canada database, which is called the IRCC. And this database contains information on all immigrants and refugees who landed in Canada starting in the year 1985. This database provides information on country of birth, country of citizenship and residence, as well as mother tongue. And we have some preliminary data where we wanted to look specifically at this population and look at the burden of chronic liver disease and cirrhosis from 2000 and 2017. And we grouped these individuals based on the country where they were born. So overall, we identified over 27,000 individuals who were either immigrants or refugees between that time period who had a diagnosis of cirrhosis. And what I've done here in this preliminary graph is I have broken down what the cause of cirrhosis was, as well as where these individuals were born. So looking at overall causes of cirrhosis, the largest burden of disease comes from individuals who were born in the Asia-Pacific region. And most specifically looking at chronic hepatitis B, this is where the majority of individuals would be coming from. This is next followed by individuals from Europe of approximately 20%, Africa and the Middle East at 13%, and the Americas at 13%. But you can see that the region of birth varies based on the cause of underlying liver disease. And in the next couple of slides, I'm going to finish by looking specifically at the Asia-Pacific region, given that it compromises the greatest burden of cirrhosis within the immigrant population. So just a reminder to the audience what geographically represents Asia-Pacific. There's 4 regions I'm going to talk about specifically. So when I talk about East Asia, I'm talking about China, Hong Kong, Japan, North and South Korea, etc. Within this region of Asia-Pacific. When I talk about South Asia, this is going to be this region here, which comprises India, Pakistan, Afghanistan, Bangladesh, and Sri Lanka. When I talk about Southeast Asia, these countries would include Cambodia, Thailand, Laos, Malaysia, Vietnam, etc. within the southeast part of Asia. And finally, when we talk about the Middle East, this would include countries such as Egypt, Iran, Iraq, Saudi Arabia, Israel, Turkey, etc. So in the next slide, what we did is we took the 27,000 individuals who were diagnosed with cirrhosis, And then we took each sub-region and looked to see what the most common causes of liver disease were from these regions. So we classified it either NAFLD, hepatitis B, C, alcohol-related disease, or autoimmune and other conditions. So looking at the top left here, East Asia. So this is, again, China, Japan, North Korea. The majority of individuals with cirrhosis born in these areas have cirrhosis secondary to chronic hepatitis B, but you'll note the large proportion of individuals who also have non-alcoholic fatty liver disease, as this is becoming not only a North American, but a global epidemic. The contribution of hepatitis C, alcohol, and autoimmune conditions is much less in individuals who were born in East Asia. This is in contrast to individuals from South Asia. So again, this is from the India, Sri Lanka, Pakistan region. The majority of individuals from South Asia diagnosed with cirrhosis actually have non-alcoholic fatty liver disease, and quite a substantial proportion also have alcohol-related disease and hepatitis C. So you can see how these two graphs differ, even though they're both populations are from the Asia-Pacific region. Next, we looked at individuals from Southeast Asia. Again, non-alcoholic fatty liver disease is the predominant cause, but there's also a significant proportion of individuals with chronic hepatitis B and chronic hepatitis C. Finally, looking at the Middle East, the majority of individuals with cirrhosis have non-alcoholic fatty liver disease, almost 80%. And this is very consistent with recent data coming from the Middle East, showing that up to 40% of the entire population has underlying non-alcoholic fatty liver disease. And there's about an even distribution of the other causes of chronic liver disease within the Middle Eastern immigrant population in Ontario. Some of the limitations of this data, as I mentioned earlier, is that we're only able to capture individuals who immigrated after 1985. So anybody who landed in Canada prior to that is not going to be able to be identified within these databases. Also, we are unable to identify second generation or higher groups of individuals born to immigrant parents. However, within ICES, there's also a surname definition that we are able to utilize, which can identify individuals from a Chinese or South Asian ethnic group. And additionally, there's the opportunity for us to link with the Canadian Organ Replacement Registry, which contains information on all individuals waitlisted and who had received liver transplantation. And we can gain some information on the ethnic background of these individuals as well. So this was a preliminary look at cirrhosis disease burden within this population, but we still have a lot of work to do to really understand what has led to this and what we may expect in the future. So to summarize, the burden of cirrhosis has increased in Canada over the past 2 decades, driven mostly by hepatitis C and non-alcoholic fatty liver disease. However, by the year 2040, 75% of all new diagnoses of cirrhosis are anticipated to be secondary to NAFLD, with the highest increases anticipated in menopausal females. There's some concerning trends that are seen for alcohol-related disease and chronic hepatitis C in younger birth cohorts, and this is expected to continue to contribute to cirrhosis disease burden to the year 2040. And therefore, as a community, if we're going to address chronic liver disease in Canada, will require a multidisciplinary effort to prevent and manage not only non-alcoholic fatty liver disease, but also alcohol-related disease and hepatitis C in younger generations. And finally, the causes of cirrhosis within immigrant and refugee populations varies considerably based on the region of birth, suggesting that targeted interventions for education or management may need to be developed based on country of birth. So I want to thank the audience for your attention, and we will be taking questions later on in the session, and I'm happy to entertain any questions. Thank you.
Jennifer, thank you very much for this excellent review of the cause of liver disease and burden of liver disease in Ontario in general, including current etiology of liver disease, as well as the projection over the next few decades. I think that is really eye-opening to listen and hear about what is in front of us, especially as we are heading toward the burden of fatty liver disease, which seems to be one of the major head or wave in front of us. Also, the goal of this seminar this morning is to look and study access to liver transplantation among the immigrant population and minorities. And I think that your review of what the burden of liver disease is among various communities and various immigrant population was quite interesting. And the differences among what you exactly pointed as Asia, various area of Asia, is also quite impressive. Thank you for this. And as you mentioned, we are going to take all the questions at the very end. I encourage everybody to submit their question if they have questions through slido.com, #AM2. And with the setup of presentation from Dr. Fleming, we can move on to our next two speakers who are going to speak more details about burden of liver disease in different communities. And our next speaker is Dr. Natasha Chandak. Dr. Chandak is a hepatologist who is practicing at William Osler Health System. She is a very good collaborator that works very closely with us at the Transplant program. She is an adjunct professor of medicine at University of Western Ontario and a clinical affiliate at the University of Manitoba. Most importantly, her collaboration with us includes not only referral of the patients who require a liver transplantation from her community to us, but also she subsequently continued to follow these patients once they have received their transplant and take care of them for a longer period. Natasha, without further ado, we are looking forward to hear from you on the burden of end-stage liver disease in the South Asian population in Brampton, Ontario.
Thank you and good morning. I thank the audience for tuning in this morning and the wonderful introduction by Nazia. So I will begin my presentation. So just to begin with, I just want to emphasize the geocultural diversity of South Asians living in Canada. As Dr. Fleming mentioned, South Asia refers to the region that's noted on this map. And we can appreciate, for example, in India, there's a population of 1.366 billion individuals. Pakistan is also a very highly populated country with 205 million individuals. We also have other nations in South Asia, including Nepal, Bangladesh, and not shown on this map of Sri Lanka, which has a population of just under 30 million. When we imagine studying South Asians, we need to bear in mind that there's a tremendous amount of diversity within this region. So for example, if you look at India as a nation, we can see a lot of variation in types of cuisine that citizens would consume. It varies quite significantly from northern India down to southern India. There is a lot of variation in terms of languages spoken, religions practiced, and so forth. So when we're trying to study a very diverse community who has now immigrated into Canada, we do need to be sensitive to the tremendous diversity within this group. As you know, over the course of the last few decades, Canada has developed an increasingly higher proportion of visible minorities. In 1981, we only had less than 5% visible minorities. And as the decades have gone on, we're projected to have a portion as high as 35% by the year 2036. Presently, the total population of Canada is comprised of 3% of the population as coming from South Asia. When we look at Ontario, we can look at in further detail the breakdown of visible minorities within our province. And we can see that South Asians represent approximately 30% of the population, or the largest proportion of visible minorities. I also want to point out that the South Asian community is among the fastest growing community of visible minorities. I now want to talk to you about the city of Brampton, Ontario. And Brampton, as you'll soon learn, is an ideal population to study when we're trying to understand health issues that South Asian Canadians face. The city of Brampton has a population of 600,000 individuals. Brampton is Canada's 9th largest city, and it's the 4th largest city within Ontario. The growth of Brampton has been extremely rapid over the last 5 years. In fact, it's grown at twice the rate of the rest of the province in terms of population, and it is the 2nd fastest growing city in Canada. The other unique aspect of the demographics of Brampton is it is actually the nation's youngest population, with an average age of citizens at below age 35. Brampton also enjoys tremendous cultural diversity. There are 89 languages spoken within the city, and citizens come from 209 different cultures. When we look at the percentage of visible minorities in Brampton, it's substantially higher than that of Canada as a whole. 66.4% of residents of Brampton are visible minorities. And when we look at this visible minority population within the city, we can appreciate that South Asians are almost 60% of the visual minorities, followed by Black Canadians and Chinese Canadians. There is, in addition to a lot of diversity of citizens with respect to country of origin, we do see some religious affiliation variation as well. Now, we need to bear in mind that on survey data, like census data, there is a lot of citizens who don't necessarily answer this question of religious affiliation, but approximately 56% of residents are Christian. And the city does have just under 10% of residents who identify as practicing Sikhism, Islam, or Hinduism. The latter 3 faiths, of course, very common in the South Asian population. It is important for us to understand the religious faith of our patients because, as you can imagine, this has a tremendous bearing on how patients perceive health, how they may make healthcare decisions. When we look at the languages in Brampton, there is certainly a great diversity. Most citizens of the city do indicate that English is their first language. But that being said, the mother tongue language is different than one's first language. So 251,000 residents have a non-English mother tongue language. And you can see that the Punjabi language is spoken as a mother tongue in almost 1 in 6 residents. And this is followed by Gujarati, Urdu, and Hindi. And just for the audience that may not be familiar with these languages, if you're able to converse in Punjabi, you're usually able to converse in Urdu and Hindi to patients. But Gujarati and some of the other South Indian languages are phonetically very different. So it's very hard to communicate with those patients unless you, of course, speak that particular language. It is my experience as the only hepatologist at Brampton Civic Hospital that the majority of my South Asian patients, especially if they are older than the 5th decade of life, strongly prefer communicating in their mother tongue language. And it's also my perception that issues around connecting patients of South Asian origin to transplantation do need to evolve for us to improve access. better ability for us to translate for patients. I think that language is a barrier that we can hopefully work toward rectifying. And thankfully, both Toronto and our hospital do have translation services, but it can be intimidating for a patient who doesn't feel comfortable in English to speak about such personal issues as their health, and even to try to broach the subject of transplantation. I now want to talk a little bit about the health status of residents in Peel, and I'd like to remind you of what Peel Region is. Peel Region is comprised of 3 cities: Brampton, Mississauga, and Caledon. And just to remind you, Caledon, in case you're not familiar with it, is a much different city than Brampton in terms of ethnic breakdown. So in some sense, Caledon may be more similar to a city such as London, Ontario. Residents in Caledon are primarily Caucasian and would come originally from Europe or are multi-generational Canadians. And this is in contrast to what I've told you about Brampton. The demography of Mississauga is very similar to the demography in the city of Toronto. So approximately 50% of residents of Mississauga are Caucasian. When we lump Peel as a region and combine these 3 cities, we are getting a slightly different demographic background than we would if we just look at Brampton. And there would certainly be less South Asians in Peel region in terms of proportion, as opposed to simply looking at Brampton. So I just wanted to highlight that point for you, because I am talking a little bit about the Region of Peel Health Status Report. There is a perception on the ground in Brampton, where I work, that our hospital is overutilized. And it turns out that that's not the case. Residents of Peel Region are hospitalized actually at a similar rate to the rest of the province. And we also have a similar portion of residents who are so-called high resource utilizers than the rest of the province. Interestingly, one's immigration status is linked to how many healthcare resources one tends to use. So we know that long-term immigrants are more likely to be high resource users rather than recent immigrants or non-immigrants. I do want to mention that South Asians have unique health issues that we do need to understand further. The reality is that we don't have robust epidemiological data yet on the true prevalence of liver diseases in South Asian residents. And I'm very excited about the wonderful research that Dr. Fleming presented earlier this morning on that topic. We certainly need to expand that research and develop it further. We do know from the research that South Asian Canadians do have higher rates of metabolic disease. They have more obesity. They have higher prevalence of viral hepatitis. There is also a high usage of alcohol and, unfortunately, alcohol misuse disorder, which is prevalent in the Punjabi community. Interestingly, in studies that I have read on this topic, it doesn't appear that South Asians living in Canada necessarily have more alcohol misuse than Europeans, but I think this is an area that we do need to study further. It is my perception in managing patients from the South Asian community that even though alcohol misuse disorder may not necessarily be more prevalent, what does appear more prevalent to me is alcohol-related liver disease. And there may be genetic reasons for that. There may be other cofactors of chronic liver disease that are making our South Asian patients more vulnerable to alcohol-related liver disease, including the presence of metabolic syndrome. This slide summarizes for you South Asian Canadians' risk factors for various liver diseases. The first point I want to make is that because South Asians are born in nations which have higher prevalences of viral hepatitis, it's not surprising that they would be at greater risk to have chronic hepatitis B and C. And often screening was not done in their native country. As you may know, when patients immigrate to Canada, they are screened for hepatitis B, but unfortunately, they're not screened for hepatitis C. And we're currently working with our primary care providers in this city to try to improve screening for viral hepatitis C. I want to reference to you a wonderful article out of researchers at McMaster, which looked at 5.8 million individuals through a systematic review and meta-analysis of 50 different studies, looking at South Asians living in Canada. And what they found is that South Asians in Canada have much more higher prevalences of many diseases as opposed to Caucasian Canadians. These include more than a twofold risk of having diabetes, a 10% higher chance of having hypertension. South Asian Canadians also have lower HDL cholesterol, which is our good cholesterol. We also have noted in the research that male South Asians have 3% or more higher percentage of body fat, and females 4.1% higher percentage of body fat. Research has also indicated that South Asians in Canada are more sedentary and consume diets higher in refined carbohydrates as compared with Caucasian patients in Canada. Now, you may be wondering, why am I talking to you about metabolic syndrome today when we're focused on liver disease? And the reason for that is each and every risk factor that I've mentioned to you of metabolic syndrome is a risk factor for liver cancer, is a risk factor for non-alcoholic fatty liver disease, which Dr. Fleming has indicated to us is the #1 chronic liver disease in our nation. So I want to now try to begin to summarize for you the burden of liver disease that we see in South Asian Canadians. I mentioned to you this slide, which I think is extremely important. This slide tells us the leading causes of potential years of life loss. And in terms of statistics, this is my favorite statistic to go to when I'm trying to explain to patients or other healthcare providers the importance that we focus on chronic liver disease in our society. Instead of just looking at mortality, what potential years of life loss statistic looks at is the life that an individual patient should have lived but cannot. So for example, if we have a patient with liver cirrhosis who passes away at age 40, she has lost many potential decades that she should have lived. And in some sense, that statistic also gives us an indication of the loss to society that death has held. Not to say that a death in a 95-year-old from a myocardial infarction is not as important an event, but we can just appreciate the greater burden that a younger death may have from a chronic liver disease. So with that in mind, we see cirrhosis as the 7th most leading cause of potential years of life loss. And I think that gives us an understanding of the importance of this disease in Peel region and indeed across the country. So what do we know about non-alcoholic fatty liver disease in South Asia? Dr. Fleming has indicated to us that non-alcoholic fatty liver disease is the #1 cause of cirrhosis, and unfortunately will continue to become an increasing burden in terms of end-stage liver disease as our population ages. We are obviously in a mad rush to find therapeutic options for patients before they get cirrhotic, but unfortunately at this time, there's no therapeutic drugs on the market that can actually reverse this disease, and certainly not to reverse cirrhosis. In South Asia, we do understand from prevalence data there that non-alcoholic fatty liver disease is extremely common and may in fact be much more common than it is in North American studies. So North American studies, such as that of N. Haynes, generally said that the prevalence of non-alcoholic fatty liver disease is in the order of 20–25%. When we look at studies out of South Asia, however, the prevalence data is much higher, often over 50%, depending on what study you're reading. So we can imagine a scenario when we have immigrants that are coming from this region and now establishing themselves in Canada. We are dealing with a very important health issue that we need to identify in this community. What about viral hepatitis? So I've mentioned to you that viral hepatitis prevalence is certainly higher in South Asia than it is in Canada. And as such, we can correctly infer that our immigrants from South Asia are having more rates of hepatitis B and C. Unfortunately, ethnicity data is not collected by public health, so I cannot share with you this morning the actual prevalence of hepatitis B and C in the South Asian population. Overall in Canada, estimates have been, for example, for hepatitis C, that 0.5 to 0.8 of the population has this virus. Recent important studies by researchers both in the United States and Canada have taught us that baby boomers have a threefold higher prevalence of hepatitis C as compared with the general population. And an individual I spoke to at Peel Public Health has told me that that's roughly a similar rate that we're seeing in South Asian residents in Peel. So we really need to ramp up our screening in the region, because if we can cure and prevent end-stage liver disease in this group of patients, hopefully we can reduce the need for transplantation in some individuals. So I now want to talk to you about the burden of advanced liver disease for patients needing hospitalization in the city of Brampton among South Asian patients. I'd just like to let you know that Brampton Civic Hospital is the hospital from whom I've obtained data. And the hospital is the only admitting hospital within the city. So we can thus infer that most residents in Brampton who require hospitalization for end-stage liver disease would generally come to our hospital. We obtained data from the discharge abstract database of our hospital, as well as our electronic database, which is called Meditech. And what we did was we looked at discharges between January 2015 and December 2019 with a diagnostic code of cirrhosis or end-stage liver disease. We recognized that alcoholic liver disease is very common in this population. So we decided to stratify patients by alcoholic liver disease as compared with non-alcoholic liver diseases. We did take basic demographic data, but unfortunately, data on ethnicity to understand the origin of where patients come from was not available in our database. This graph shows you the number of admissions to our hospital for end-stage liver disease. And there are roughly 400 admissions a year at Brampton Civic Hospital for end-stage liver disease. This bar has a blue and red bar. The blue bar is patients who had a primary diagnosis of cirrhosis, and the red bar as a secondary diagnosis of cirrhosis. I don't want you to get too hung up on primary versus secondary. Often when patients are being admitted for cirrhosis, they will have a precipitating event. This may be sepsis, it may be renal failure, or a GI bleed. And the important thing that we want to capture is the diagnosis of cirrhosis. I also want to emphasize for you again that I can't tell you this morning how many patients on these bars are actually South Asians. However, if we go back to the statistics, if approximately 50% of the total population of Brampton is South Asian, it's my experience as a hepatologist that more than 50% of the patients I'm seeing for cirrhosis diagnosis in the hospital are South Asians. So it's my belief that South Asians are overrepresented, but of course we need solid data to prove that observation. But you can easily infer that when I'm talking about these numbers, approximately half are South Asians, and that would be similar to the portion of the population in the city. This slide shows you admissions to hospital as broken down by a diagnosis of alcoholic liver disease in blue versus non-alcoholic liver diseases, of which there are, of course, many, such as hepatitis B, hepatitis C, non-alcoholic fatty liver disease, and so forth. And what you can see is approximately 30% of these admissions are for alcohol-related liver disease. When I see that statistic, I'm very motivated to do everything I can as a health provider in the community to try to help patients with alcohol misuse disorder. So we try to partner with our colleagues in mental health, because clearly some of these admissions we can prevent. And that's, I think, a major challenge that we have in the city of Brampton. This slide shows you the length of hospitalization for liver disease, and these numbers are absolutely astounding to me. So patients are staying in hospital about 14 days. That is a lot of healthcare resource utilization, not to mention a lot of cost to our public healthcare system. On average, a day in the hospital is over $1,000. And we're now, of course, unfortunately, looking at a second wave of COVID, and anything we can do to be utilizing our healthcare resources in a better way is obviously our objective as a healthcare community. And this just gives you a sense also of how tremendously sick patients with end-stage liver disease are to need a 14-day hospitalization. This slide is also very alarming to me as a clinician. This slide is showing us how many patients who are admitted for cirrhosis need the intensive care unit. And you can see roughly 25% of patients need the ICU. And there are very few diseases I can think of that take up as many resources as end-stage liver disease. In the ICU bed in Ontario, it costs roughly $2,000 a day. And when I speak to our health administrators on the ground in Brampton, they tell me that patients with end-stage liver disease typically need much more resources than the average ICU patient. The reason for this, often they have multi-organ failure when they are in the ICU. They're typically intubated, mechanically ventilated, sometimes needing dialysis, often needing inotropic support, and sometimes needing urgent endoscopic treatments and so forth. So you can imagine the amount of resources this disease is consuming. This graph is showing you the number of hours that patients are staying in the ICU. And this, again, is mind-boggling numbers to me. So patients are staying in hospital with cirrhosis 8 or 9 days. That just gives you, again, a sense of how tremendously sick patients are. And I didn't show you mortality data and other data, which I hope to extract in the future. But just to highlight the tremendous resource burden that this disease plays. So I now want to switch gears a little bit and start to begin to talk about some transplant issues as it pertains to South Asian Canadians. So as you know from the research and what Dr. Fleming, of course, has indicated to us as well in the beginning of this presentation, South Asians have a high and rapidly growing incidence of chronic liver disease. Despite this, and despite the fact that in Asia there are some very stellar live donor programs, the contribution that South Asians have to both deceased donation as well as live donation is actually relatively small. And this is a very important research question that we need to explore further in terms of why is this contribution small? What do we need to do to expand the donor pool so that our South Asian patients have greater access to transplantation? So I now want to talk to you about whatever data that we do have. And the reality is that we desperately need data, and we don't have robust data in South Asians. And thankfully, some of our researchers on this panel will be working toward answering this question. Based on United Kingdom data, it does appear that South Asians in that nation do have comparable access to deceased donation with comparable outcomes to white citizens. But we don't have, as I said, robust data on live donation. This study is looking at the SRTR database, which is a US-based database on organ recipients for liver transplantation. And this is an interesting study. I just want to explain to you what we're looking at so that the slide makes a little bit more sense to you. So you'll see 4 bars next to each ethnic group. And as the bars get lighter in color, these are patients who are sicker. When we allocate organs, we use something called the MELD score, which stands for the Model for End-Stage Liver Disease. And in Ontario, the average MELD score for transplantation is probably in the mid-20s, just to give you some reference. What you can see is that in the very sickest of groups, so patients with MELD scores between 30 and 40 in the United States, we're seeing that Asian patients have 46% less liver transplantations than the same patient who is Caucasian. So this is a major discrepancy that we do need to understand further. Now, unfortunately, in this type of a database that was used, we don't know the breakdown of these Asian patients. We don't know how many come from Southeast Asia versus South Asia and so forth. But clearly there's a discrepancy that we do need to research and explore further in deceased donation. What about live liver donation? This study that I'm going to talk to you briefly about is looking at data from the United Network for Organ Sharing, which is the federally funded group that monitors transplantation activity in the United States. And what this research group found is that there are significant discrepancies in terms of access to transplant in those who belong to a racial minority group. So patients who are ethnic minorities are receiving disproportionately low percentage of live livers. And when the researchers looked into why this is occurring, the main reason they identified is that there is less interest by potential donors. And this underscores a need for us in the healthcare community and in the research community to really understand why this discrepancy is occurring. We need to provide more education and be more effective at providing outreach to potential donors of minority backgrounds so that we can increase the potential donor pool for these patients. And interestingly, this trend is something that has also been demonstrated in kidney donation. So there's something going on that we don't yet understand. Is it a financial issue? Is it a fear issue? What is the issue that's preventing patients who are South Asian from obtaining potential donors? Obviously, we do lack specific data on South Asians, and hopefully we'll work toward acquiring that through upcoming studies. I leave you with 3 or 4 closing remarks for my portion of this talk. So first of all, we know that transplant recipients are a highly selected population. And I cannot emphasize enough the joy that I get as a hepatologist to receive patients back from Toronto General Hospital who have a new life, who have many more years to live, who have an excellent quality of life thanks to transplantation. And it should be noted that research has clearly demonstrated to us that South Asians have the same benefits to transplantation as all other ethnic groups, including white patients. And therefore, we need to do everything we can to bring this therapy to this group. We know that South Asians have a high burden of cirrhosis and a high theoretical need for transplantation, but I do emphasize the need for more robust data, and I look forward to Dr. Fleming's work in this area. We also desperately need to understand the barriers that South Asians face in Canada on getting onto a transplant waitlist, particularly for liver, as we talk about this morning, including live liver donation. Specifically, we need to explore every possible barrier and try to find solutions. This might be a transportation barrier. It might be a language barrier. It might be a financial barrier, patients not being able to take time off of work. It might also be a cultural issue. Older patients may, through cultural practices, feel awkward in actually reaching out to their family members, asking for this type of gift. So those are areas that we look forward to exploring. And I thank you for your time this morning.
Natasha, thank you so very much for this very detailed analysis of the South Asian community in Brampton, the very eye-opening complexity already within this community in terms of languages, the various cultures, and also walking us through the complexity of liver disease and their access to liver transplantation. I think that your analysis in terms of barrier to liver transplant are extremely important and certainly very important for us to know as we are embarking in this in this new path to try to increase access to liver transplantation for our diverse minority. And all your points in terms of language barrier, cultural barrier, financial barrier, and even some logistic barriers such as transportation and bringing them to hospital, etc., are extremely valuable for us to study and try to help resolving them so that this community have better access to liver transplantation, but also to live donor liver transplantation. Thank you very much again for this analysis. I think our next speaker is Kalina Yin. She is our nurse practitioner at the Toronto Center for Liver Disease for probably over 3 decades already. I am sure that everybody who is listening this morning and has been to the Toronto Center for Liver Disease has met Kalina. She is a long-standing figure in this center and works very, very closely with the Chinese community particularly. And she is going to walk us through the burden of liver disease in Chinese community and the perspective from the Toronto Center for Liver Disease in terms of access to transplantation. Kalina, thank you very much.
Okay. Well, thank you, Dr. Sausna, and I want to thank the organizer really to give me this opportunity to talk about liver disease in Chinese community. Now, there really an awful lot of research or studies or reports about liver disease in Chinese Canadians. So what my presentation today would largely from my experience working with a lot of Chinese patients over my 30 years of nursing career. So for the next 15, 20 minutes or so, I will first share with you some statistics from our center on liver disease among Chinese Canadians. And I'll tell you what is the leading cause of liver disease in Chinese population and what are the barriers to accessing liver care, including liver transplantation and live organ donations. And last but not least is something very dear to my heart, is about the Chinese hepatitis B peer support group that I helped initiate about 10 years ago. So let's look at the ethnic diversity who come to our center, like the liver clinic. So as of last Friday, September 11th, so we have a total number of a little over 13,000 patients registered in our electronic database. And out of that number, as you can see here, about 2,100 are Chinese. And these Chinese patients, they're mostly immigrants from either mainland China or Hong Kong. Now, I must clarify that these numbers are no means represent all the patients that we see in the clinic. It's because we have 2 Chinese-speaking hepatologists, and their patient data have not yet merged into the electronic database. So my best estimate of number of Chinese patients to flow through our clinic, I would estimate around 3,500. But let's just focus on these 2,100 patients that are registered in our database. So what is the most common liver disease that we're seeing in our Chinese patients? So you can see in the diagram here, more than 75% of Chinese patients who come to our clinic because of hepatitis B. And when they have hepatitis B, we also have this number of patients have cirrhosis. So really about 1 out of 4 patients with hepatitis B, they have cirrhosis. And we also have over 100 patients have liver cancer. So that's roughly about 1.8% of our patients have. So I sort of always tease my patients, joke around with that. Well, remember B is bad. So when you have hepatitis B, it can give you cirrhosis. And once you have cirrhosis, you are at high risk of liver cancer. So what is hepatitis B? Just a few words so for people to be familiar with this virus. So hepatitis B is a virus infection that affects the liver. It is a totally different virus from the other viruses, such as hepatitis A or hepatitis C. However, similar to hepatitis C, hepatitis B is also a blood-borne virus. What I mean by that is the virus is carried in the blood. So in order for me to become infected with this virus, someone who's been infected with the virus have to get blood, contaminated blood has to get into my blood before I can get infected. So it's really a close blood-to-blood contact. In Canada, the most common route of transmission of hepatitis B is from sex. In fact, here, hepatitis B is considered as a sexually transmitted disease. But in Asian countries where hepatitis B is highly endemic, the most common route of transmission is from mother to child. And how does that happen? Is mostly during the delivery process. During the delivery, there is a very high risk of blood transfer from mother to baby. And that is the time when the transfer of the transmission occurs. And when the baby had hepatitis B, the immune system is not mature. So it ends up that the child will carry this virus for a long time in their life. And hepatitis B does not give you symptoms until the liver is severely damaged. And if someone has active hepatitis B and left untreated, about 1 in 4 will develop cirrhosis. And once cirrhosis is developed, about the risk of developing liver cancer is about 1 in 20 per year. And that is not an insignificant number. As we all know, we do have very effective hepatitis B vaccine available. And there are also effective antiviral treatments available, almost for 2 decades. But the question remains is, why are we still seeing patients, like especially Chinese Canadians, have increasing number of cirrhosis and liver cancer? Is it because they're unaware of the disease, because they're not seeking care, or they're not receiving treatment? I think that's probably all of these above. So over all my years, I'm talking to Chinese patients with hepatitis B. These are the most common misconceptions that I got asked and I heard from my patients. First one is, I'm a hepatitis B carrier. I have no disease. So carrier is really a bad word. It's a misleading word in a way. It's because when people think, well, I'm just carrying the virus, it's just in my body, it's not doing anything, so I'm fine. But as long as you have the virus in the body, there is always a chance of activation. There's a chance of active disease. So nowadays, we teach our patients, we're avoiding to use the word carrier. Instead, we'll tell our patients whether your hepatitis B is active or not active. And the misconception is, I have no symptoms. I do not need to see a doctor. Again, that is wrong, because hepatitis B does not give you symptoms until the liver is severely scarred. Again, I have no symptoms, so my hepatitis B is not serious. And again, that is wrong, because even in early cirrhosis, as Dr. Fleming has talked about in earlier section, that early cirrhosis also does not give you symptoms. Hepatitis B can be transmitted by sharing food. Again, that is wrong. It's mainly transmitted from blood. I have liver cancer, I'm going to die. Well, yeah, you're going to die if we find the cancer when the cancer is as big as your liver, or the cancer has already spread to the rest of your body. So the main thing is we have to find the cancer when the cancer is small. And there are treatment options nowadays for liver cancer, including liver transplant. So really early treatment for patients with active hepatitis B is really key to prevent the disease from getting worse. In fact, patients with cirrhosis, because of hepatitis B, cirrhosis can regress. Now, I put here can be reversed. It may not be an appropriate word because it's more a regression of the scar tissue. So if you are taking long-term antiviral treatment, the liver, the cirrhotic liver, can go back, like, have less scars, become softer. And so nowadays, people with hepatitis B, with cirrhosis, they're not going to die of hepatitis B if they start treatment early, if they continue adhere to the long-term antiviral treatment. But the problem is, because when you have a cirrhosis, you're also at a higher risk of liver cancer. Now, long-term antiviral treatment can lower the liver cancer risk, but unfortunately cannot totally prevent it. So liver cancer is now the leading cause for transplant among Chinese Canadians nowadays. And we need to realize that liver transplant can save life. An interesting point is Dr. Chandok that talked about the transplant concept in Southeast Asia. It's also the same, it's very similar among Chinese Canadians, is that, like, I do have Chinese patients who receive transplant because of liver cancer, but I have not had one Chinese patient who receive live liver donors, and it is uncommon in Chinese patients. So next, I want to point you out to this studies that we have done from our center, and it was published in 2009. What we did is we surveyed about over 200 hepatitis B patients, like Chinese patients, and we gave them a questionnaire. This is mostly a knowledge-based questionnaire because we want to find out how much knowledge that our hepatitis B patients have, and what are the barriers that prevent them from undergoing screening or monitoring or treatment of their hepatitis B. So these are the highlights of what we learned from our studies. So out of the 7 barriers that we listed for our patients, the top 3 barriers that our patients reported that prevent them from accessing care is time, inconvenience, and language. And the major misconceptions that I gather from our patient is that severe liver disease is always symptomatic. In other words, when I have no symptoms, I have no severe disease. And I think that also speaks to why they think time is a barrier, because, well, if I don't think I have disease, then why I spend the time in coming to see you to the clinic when I can do something else. So in terms of knowledge gaps, is we only have a little over half of our patients cohort know what cirrhosis means. About 63% know about antiviral treatment, despite the fact that back in 2009, they are very effective antiviral treatment already. And social stigma. 2 out of 3, the patients believe that they were stigmatized by hepatitis B. And about 1 out of 3, they were ashamed of their hepatitis B. And because of this, they feel ashamed. They don't want to discuss hepatitis B with their family or friends. And it is not unusual. And I've seen it in many of my patients. And they will say, well, when you call me, don't leave messages on my phone because I don't want my family to know about my hepatitis B. So those are the what we learned from the study. But from my personal experience working with Chinese patients with hepatitis B, and I think these are more barriers. There are more barriers for them to access care and treatment. So along the same line about knowledge, I think there's also a lack of awareness about their risk of getting hepatitis B. I have patients who are born in Canada, and they said, well, I'm totally shocked when they find me, I have hepatitis B because I'm born in Canada. But their parents came from high endemic areas. So when the parents came from China, from Hong Kong, they remain at risk of having hepatitis B. Remember, I said that it's from mother to child transmission. There's also a lack of awareness about healthcare system in Canada. I have patients tell me is that, well, I don't bother to come back to see you because I cannot afford to pay the medication. I don't have a drug plan, and I'm a middle class, and I don't have the money to pay for the antiviral. Back in 2009 or 10, the antiviral is very expensive. It's like you can cost up to like $8,500 a year. And that is a lot of money to many immigrants. And there's a barrier about mistrust of healthcare system. So from time to time, I have patients who are diagnosed with liver cancer, and they decided they don't believe that they would be seen early. They are unsure how soon I will get treatment. They're not sure that they will be treated equally, that to have their liver cancer looked after. So patients, once they have the diagnosis of liver cancer, they just return back to the home country, to mainland China, to Hong Kong, and get treatment instead. And I cannot talk about barriers without talking about the cultural belief and values. So each culture has their own beliefs and values. In Chinese, like as a Chinese myself, I know that's family values. So I know some families, they actually absolutely, like, they don't want any discussion on death-related topics. So definitely death and dying are not on the family dinner table for discussion. And I also know families, in fact, I also have patients tell me that, well, don't tell my family members that they're dying. Don't tell them about the illness. What the belief is that if you tell that person, that sick person, that they're dying or they have really bad disease, then they will get sicker. You'll just hasten the death, that they will make, you will make them depressed. You will make them feel bad, and they will not have what they call a good death. And that is some of the family beliefs. And there's also this culture that they believe Western medicine can upset the body's yin and yang balance. So yin and yang is really the fundamental philosophy of life in Chinese culture. And so the yin and yang are really opposing forces, and you must be a balance in order to have harmony in life. So a lot of Chinese patients, they say, well, let me try, this Chinese herbal medicine, like for my hepatitis B, before I try Western medicine. So that is their beliefs. Again, trust. There are people who trust only credible professionals, and it depends on how reputable that the organization is. And they also believe that organ donation is a body-destroying behavior. So what are some potential strategies to overcome these barriers? So of course, education will come on top of the list. Again, educate. I think that we cannot do this is so important. But I also think how we deliver education is also important. Of course, it will be excellent if the educator or the healthcare providers can speak the language of our patients that we look after. But it is not possible. Now, I want to give you an example that we have a group of very dedicated Chinese family doctors from Chinatown, and they have organized this specifically for the Chinese community. They have the health awareness event every year. They was held in Scarborough, and it's all delivered in Chinese language. And every year, they manage to attract 800 to 1,000 Chinese Canadians to attend these events. And during the event, that is where they learn about their health, about hepatitis B. So the second strategies I put is about communication, and that, of course, include the language barrier. And some of the strategies that we can think about: multilingual clinics and use of interpreters. And at University of Health Network, we are very fortunate. We do have a language line that when we need interpreters, we can just call up the number, and then we have simultaneous interpretation right away. Now, what I observed, though, is for as a language barrier. In fact, I would say many of the Chinese Canadians, they actually are pretty fluent in English. They can understand. Of course, there's still minority that they do not speak a word of English, but majority, they do, they understand. But what I hear from my patients is that, well, I'm afraid that I do not understand the medical terms. Sometimes I don't know how to express myself. I don't know how to describe my symptoms. So these are the fear. So these are why they prefer education to be conducted in their mother tongue. The third strategy, I would say, is about convenience. Extended clinic hours, maybe. I don't know how feasible it is, but that is another strategy that we can think about. And of course, we need more studies to understand the cultural influence in Chinese patients' behavior. And last but not least, I'm going to talk about patient support groups as a way to overcome these barriers. So this is the Chinese hepatitis B peer support group that I initiated back in 2010. I must tell you the story. What is the impetus that drives me to initiate this support group? I have this woman patients with hepatitis B, and during a regular clinic appointment, and then she asked me, well, Kalina, what type of hepatitis do I have? Do I have hepatitis B or do I have hepatitis C? So that is sort of like come to my mind, oh my God, like I have looked after her for over 10 years and she is asking me that question. So I have done such a terrible job in educating my patients. So I've seen her all the time. I guess the assumption is, well, this patient has been a long-term patient, they must understand everything. And that is wrong. So yes, every time when we have an interview in the clinic, that's only 10, 15 minutes. I mean, the patients have so many questions that we might not have the time to answer the question. So that is the time when I said, well, that is something that I have to do something. So I started the conversation with a number of my Chinese hepatitis B patients, and the enthusiasm that I received was astounding. So that is how I started this group. And who they are, and they are just patients and families. So on the picture you see, this is what I call the core working group of the whole group, and they are patients, families, and there are two couples here on the pictures. So they're very dedicated, and the aim of the support group is to, as I say, to provide support to patients with hepatitis B, to give them information, from experts, from us, like, you know, we are the experts in hepatitis B. And also, we also find that why they want to come is because they want to share information. They want to share the stories. So I'm going to show you the kind of activities that we have done so far. And we have been holding education seminars at least 6 times a year. And during the seminar, like the patients, they share the stories, they share like the experience of the hepatitis B. And we also do a lot of outreach events. And it was last year, 2019, the peer support group, we were in Chinatown, participate in the Chinatown event. And we are there and have a booth. We support and we promote hepatitis B awareness. And here, again, it was last year, we participated in one of the health events. We promote hepatitis B screening. And we also have newsletters that we send out to our patients in the clinic. And we also send it to in the community. And one of our hepatitis B volunteers is a Tai Chi master. So we have Tai Chi classes and teach our hepatitis B patients about exercise and so forth. So right now we have a support phone line for our hepatitis B patients. We have an email address. We recently have also developed a website. So all this work was done by our hepatitis B patients, totally volunteering their work and their time in supporting this group. So I also want to talk about the point of care testing project that the support group has done in the past couple of years. So what is a point of care testing? So usually, remember, if we want to find out whether we have hepatitis B, we need to go to our family doctor, have a blood test done, and then we send to the lab and find out, right? But this is a point of care. So meaning that it's just a finger prick, and just one drop of blood from your finger, and then we'll put it on a slide, and we will have the result in about 20 minutes. So that will, in 20 minutes, we can tell someone whether you have the hepatitis B or not. So we have this project, we're very happy, and then we decided, well, let's target the high traffic Chinese shopping malls. So the first 2 events, we went to the first marketplace in Markham, and we went to the Chinatown Center on Spadina. And really, to our disappointment, we have low uptake rate. We did not have like tons of people coming to us. And we sort of afterwards, we debriefed, and why is that? Like, you know, we have less than 50 people come to our booth after we spend a whole day standing, like have a booth in the mall. And I think, and then we realized that, look at this huge banner we have. It says hepatitis B screening. So we find out that people, the Chinese Canadians, they don't want to come to us in a public place because they don't want to be seen by their friends or whoever that, well, because I might have hepatitis B. So that is speak to us about the social stigma. So we learned the lesson. So we changed our strategy after these first two events. And since then, we only go to smaller community centers. We go to health events, and we have much better result. And that is the lesson we learned. So next, I want just to tell a quick member story. So let's call her Anna. Anna attended one of our support group outreach event in the community, and then she find out, what we've done. So why is she interested? She's interested because her husband was recently diagnosed with hepatitis B and also, unfortunately, inoperable liver cancer. And that's why she's so happy to find us. And she came to our meeting. And during the meeting, she's able to talk about her husband's illness, and she's able to talk about her burden and experience as a caregiver. And she afterwards told us, oh, it's such a relief that I can talk about my experience, talk about my husband's illness. So her husband died a few months later, but she continued to become part of our member. And I think that is what support group is about, to give them support, to help people to talk about their experience. And the question remaining in her mind is, could her husband's death outcome be reversed? Will hepatitis be identified and treated early? And would transplant be an option? So I cannot say that yes, for sure, but I think there's always a possibility if the husband knew about hepatitis B earlier and treated earlier. So the question, this is all about transplant. So I was thinking about, is organ donation in Chinese culture? That I don't think I can answer that question. So I dig into some literature and I try to understand about organ donation in Chinese Canadians. And there is really nothing much that I can find, but I find something is about China. So people, as I said before, we have a lot of Chinese immigrated from mainland China. So back in China, historically, organ transplant, they use organs from executed prisoners. Well, is it ethical? Well, it is ethical. This culture is generally accepted because the way these people see it is, for the criminals, it's a payback for the crimes that they have committed. It's sort of like, an eye for an eye, so to speak. So not until 2014 in China, there is a national voluntary organ donation system established. So organ donation is still, this concept is fairly new for people who live in China. And in 2019, there was an American study that was published. They looked at what are the barriers to organ donation among Chinese and Koreans in North America. And they listed the 4 top barriers to organ donation. The first one is lack of knowledge, because if they don't know about organ donation, they will not do it. And there's a distrust of healthcare and distrust of allocation system. And there is this value about the desire for intact body after death. And again, also is the family values about the meaning of death. So that is in North America, like among Chinese and Korea. So what is the attitude like in Chinese Canadians? What are the attitude like towards living organ donation, and how willing are we as Chinese Canadians to be a life donor? We don't know, and that is why we need to study. So I think with Dr. Fleming's studies, the upcoming studies, and I'm really happy and really looking forward to what she will find out from the studies. So in summary, hepatitis B is the most common cause of liver disease in Chinese Canadians, and liver cancer is the most common indication for transplant in patients with hepatitis B. And live liver donation is uncommon among Chinese Canadians. And I certainly think that have a support group, it is an effective approach to address liver care barriers faced by the Chinese Canadian. And definitely we need more work to improve liver care access. And this work, it should be what I call culturally responsive, like looking into consideration of the Chinese culture and beliefs. So that's all I have to say. So, and thank you very much for your attention.
Kalina, thank you very much for this amazing perspective in Chinese communities. I think we learned a lot from your presentation in terms of the cultural barrier, and some of the barriers seems to be common with other communities, such as, lack of knowledge about the liver disease, the progression of liver disease, but some see a lack, barrier in terms of language and access to medical care. And there are also some unique perspective to Chinese communities based on their cultural belief and that needs a specific approach, certainly toward this community. And we are very fortunate to have you working so closely with this community, and I am very impressed of all the work that you have established in terms of outreach and all the efforts you put into this point of care and educational toward this community, and hopefully these are all valuable information for us as we are moving forward to improve access. So I'm going to finish by talking a little bit about living donation. But before I start my presentation, I would like to encourage again everyone to submit their question through the Slido. And we will try to answer all the questions at the end of this session. And please don't hesitate to send this question. So talking a little bit about access to liver transplantation and living organ donation, and what we learned from the presentations this morning. Before I go ahead and present the exciting news in terms of the study that we want to initiate to look at the access to transplant for our immigrant and diverse communities, just a few words in terms of liver transplantation, our program, and living organ donation. So the liver transplant program at the Ajmera Transplant Center is the home to the largest liver transplant program in Canada. We have done over 3,000 adult liver transplants since 1985, when the program was initially established. And up to now, we have done over 900 living liver donor transplants since 2000, when the program of living organ donation was initiated. And that in that year of 2000, our team felt that due to the lack of disease organ donation and the continuous death on the waiting list for patients who are waiting for liver transplant, we need to come up with other initiation and other perspectives and solution and strategies to reduce this death on the waiting list for transplant. And the living organ donation was initiated in that year. I must say also, we are going to talk a little bit about that in the next slides, but even though the living organ donation in the Western countries, definitely Canada as pioneer in the Western world for living organ donation started in 2000, it is one of the main paths to liver transplantation in many Asian countries, because in these countries, cadaveric organ transplantation due to the cultural belief is not possible. So it is not unique to Western countries. It's not unique to Canada. It's widely used across Asian countries. So in 2019, just a few more stats, the program, our program has performed over 200 liver transplantation. And I'm very proud to say that we have performed 60 live donor liver transplant last year, 48 adults and 12 pediatric. Were made possible through the living organ donation. And I'm also very pleased to say that this year, despite all the slowdown in the healthcare system across all specialties due to COVID pandemic, we have done really well in terms of live donor liver transplantation, and we are very close to do 50 live donor liver transplant as we are speaking now, and we are projecting to be finishing the year possibly one of the best year in terms of living organ donation. And again, that is despite the pandemic that we have all been suffering from. And our UHN transplant program, or Toronto General, is ranked one of the top 5 hospitals in the world. So what are the benefits of liver transplant? I think that we all have heard from various speakers in the panel this morning that patients develop liver cirrhosis, they have the compensation from liver cirrhosis, they stay in ICU. You heard from Dr. Chandak the length of admission to ICU from cirrhosis-related liver disease and the risk of death. And liver transplantation is the treatment of choice for a selected number of patients with liver failure because it allows to improve their health, to increase their life, prolong their life expectancy, improve their quality of life, etc. And however, it is also important to emphasize that not every single patient with liver cirrhosis could be an eligible candidate for liver transplantation. And these are the nuances that one has to be informed. But it's also important to acknowledge that every patient with liver cirrhosis and decompensation should be referred to a liver transplant program so that they have the chance to be assessed by the transplant team and make the final decision in terms of their candidacy for transplant, which is again their life-saving procedure. So this slide basically shows the pathway to receive a liver or any liver organ transplant. And I want to say that they are not mutually exclusive, and that is important to know. I think there is still a lot of barrier because many people don't believe that if they are on one side, they cannot have access to the other side and vice versa. So the two paths toward the liver transplantation, one is through the deceased organ donation. Every single patient who is listed in our program would be on the deceased organ donation, except perhaps a few specific research protocols. I'm not going to go into those details, but overall, majority of our patients are listed on the deceased organ donation list. And that's the path for everybody. But it also means that you have to wait for a deceased organ to become available. The other path to liver transplantation, which would be in many ways a shorter way to access transplant, is through living organ donation. So what does deceased organ donation means? It means that you are on the waiting list for transplant in the province of Ontario, and Trillium Gift of Life, as you all know, is the agency that oversees the organ donation and allocation in the province. The referral and the listing criteria are defined by Trillium Gift of Life, and the allocation of the organ is through the score that we are using, that's called sodium melt score, as well as based on the blood type and the body size. So this sodium melt score, just to go through it very briefly, because all the patients who are waiting for a transplant know or should know about this score. That is a score that assesses the severity of liver disease as well as the likelihood of dying from the complication of liver disease within the first 3 months after the score is measured or calculated. The score is very objective. It's based on parameters that are measured biochemically from the blood. So there is no subjective definition that this patient seems quite ill. It's based on parameters, 4 parameters, bilirubin, which is a measure of the liver function, synthetic function, creatinine, which is a measure of the kidney function, and INR, which is measuring the clotting in the body. And the reason for that is that all the clotting factors are synthesized by the liver. So it's again another determination of the synthetic function of the liver. And the fourth parameter in this score is the serum sodium concentration. So patients who are listed based on their sodium MELD score. These 4 parameters enter into a formula, a complex formula, and the score is generated automatically. And we know that patients who is awaiting for a deceased donor organ transplant requires to have a score close to 30 currently to be able to attract a organ from a deceased pool. And that is regardless what is the blood type. So this number is roughly about 30 in whatever blood group we are looking at. Listed patient for liver cancer are receiving exception point because their sodium MELD score at baseline is very low and they could wait for years on the waiting list. So we allocate them every 3 months. Exception points to bring them up to the top so that eventually they can receive an organ. And these scores are updated every month so that it reflects if a patient gets sicker. The second path through the transplant is through living organ donation. I mentioned that in many countries around the world, living organ donation is in some instances the only way to receive an organ. That's, for example, in Japan, 97% of all transplants is through living organ donation. Similarly, in Korea and India is really the way to have access to transplant. And in Toronto, we roughly 30% of our activities is through living organ donation, and I believe that this numbers is rising even more. The benefit of the living organ donation is that that allows access to transplant, to a life-saving transplant with minimal waiting time. It's access to an organ that is much healthier because the donor that is donating a piece of their liver to a recipient is a healthy donor. They have to go through a very specific and careful assessment, and only healthy donors are moving ahead with organ donation. And the reason for that is we want to make sure that the health of the donor remain intact throughout the process, and therefore a donor has to be completely healthy, and therefore the recipient will also receive a very healthy liver. I'm going to show you very briefly a couple of slides about the long-term outcome of the recipient of the live donor transplant, and you will see that they are very, very close to the outcome of the deceased donor recipient. And in addition, the organ donation, and particularly live organ donation, brings a deep satisfaction to donors from saving a life of a patient who would otherwise die without a liver transplant. And that's something that comes up often during the discussions. So as I mentioned, donor safety is our #1 priority. A donor has to be between the age of 16 to 60 years of age to be a donor. You have to be in excellent physical, but also emotional health, and have normal liver function and support from their family and their friends to go through this process. And most importantly, it's a voluntary choice. It can be on no way a coercion or force from anybody around them to do this, to go through with a live donation. So this is just a study that we are submitting soon for publication, where we looked at the long-term outcome of adult-to-adult liver transplant in our program. Now being 20 years initiating this live donation, so with 20 years of follow-up of the live donors. And here I just want to point out a couple of numbers. When you can see the highlighted in red on the middle column is the live donor liver transplant, and on the right-hand side, the deceased donor liver transplant. You can see that the live donors typically are younger by at least a decade from the deceased donors. And there is an equal number of distribution in terms of both male and female donors in both groups. There is about 45% of our live donors were from male donors, and similarly about 56% of the deceased donor are male. This slide shows the long-term outcome of the both patient and graft survival post-liver transplant. On the left-hand side is the patient survival. The red graph shows the live donors. The blue one, the deceased donor. You can see that during the first few years of post-transplant, at 5 years and 10 years, the outcome of the live donor is actually better than the deceased donors transplant. Just again, because these are better quality graft from younger donor, and patients are getting access to transplant a lot faster. However, at longer term follow-up, close to 20 years, the difference is no longer seen. And the reason for that is that patients start developing other complications and die from other medical condition that has nothing to do with the live donation. On the right-hand side is again graft survival, and you can see roughly the same results. And the last slide is just to show you the cause of death. And the reason I put the slides up is because I wanted to emphasize on the fact that the cause of death in the recipients of the live donor is very, very similar to the recipient of the deceased donor. And there is really no disadvantage in terms of the live donation. So during the discussion this morning with our panel, we have heard about burden of liver disease in various community, immigrant and diverse community in Ontario, and how important it is to try to increase access to liver transplant among this community. And I'm very excited to present you the research study that we have initiated in collaboration with Dr. Fleming, with the goal of looking at prevalence and incidence of liver disease and access to liver transplant and living organ donation in ethno-racial communities. That's called, the abbreviation for this research study is Access Liver Transplant. And that's a study that is funded by the Canadian Donation and Transplant Research Program. So and it was quite highly ranked in the research proposal that they received as being quite unique and very important question to address. So the aim of our study, you have heard it over and over this morning, is to describe the cause of the cirrhosis in the ethno-rational minority patient and change in the incidence of etiology and immigration over time. We want to examine the trends in rates of liver transplant and living donation by immigration status, and explore ethnicity, race, immigration, gender, geography, and socioeconomic factors, all the parameters that the panel speaker has raised from various ethno-racial communities in relation to access to living organ donation. And our hypothesis was a patient with end-stage liver disease from immigrant and ethno-racial minority communities are less likely than other Canadians to be referred for a transplant, receive a liver transplant, be a living donor, or receive an offer from a living donor liver. So this was our study. This is a two-phase study. As a first step, we are going to do a population-based study of diagnosis of cirrhosis using the tool that Dr. Fleming explained to you from the ICES. And the second part is the intervention part, where we will reach out to various community through surveys, focus groups, interviews, etc. And we are identifying a number of questions and interventions to try to access the burden and barriers to organ donation and organ transplantation and living organ donation as developed here. And finally, my last slide was on how do I become a living organ donor. This is through complete donor health history submitted to uhnTransplant.ca, and send along a copy of your blood type and wait to receive a call from our program. This is all the presentation from this morning, and we will open now the panel for the discussion and the questions that were submitted through the Slido. Courtney, do you want to go ahead and read the questions so we can answer them?
Hi, Nazia. So we've received 7 questions. We probably will not get access or be able to answer all of these questions today, given the time. But our first question is, in the data looking at causes of cirrhosis among immigrants and refugees in Ontario, do we know when their cirrhosis was diagnosed? Is diagnosis related to the healthy immigrant effect or social determinants of health that cause a decline of health after immigration? And Jennifer, maybe that's something that you would like to address.
Sure, yes. Thank you for that question. I think it's an important question. We haven't yet looked at that, but we're going to attempt to address that specific question. So from the data sets that we have, we know when an individual immigrated to Ontario, and then we know the first date that they were ever defined as having cirrhosis. So we'll be able to look and see whether or not they came to Canada with the diagnosis already, or if this was something that developed over time. And certainly you're right, the healthy immigrant effect is well known within medical literature and something that we will be looking at. There's also other ways within the ICS data that we try and look at socioeconomic status and other social determinants of health. There's several databases, so we're interested in linking to those as well to try and describe that in more detail. So I'm very hopeful that this study will shed a lot of light on some of the issues related to the burden of liver disease in immigrant populations, as well as access to transplant.
Fantastic. So we have a number of other questions, but I am mindful of time. I see there's a question on paired exchange, and then there's one on blood type. There is a paired exchange, liver exchange program at UHN, or we did our first, the first one last year, and we'll be able to provide information on that and answers to the other questions on the list. Perhaps we could just take that the next question and then adjourn, or I'll turn it over to Nazia. But the next question is around blood type. Is blood type one of the reasons why some people have trouble accessing transplants?
Yeah, I'm happy to answer that question. So blood type, yes, could be one potential reason. The organ is allocated based on the blood type. Obviously, a majority of there is a big majority of population with the blood group A. Therefore, there are more donors from blood group A, but it also means that there are more patients on the blood group A list that are waiting for organ. Blood group B seems and AB seems to be among the lower rates of blood group donors. However, their list is also shorter. So the way we always put it as transplant hepatologists is that at the end, the likelihood that you have to wait for a blood group organ, B organ, is possibly not very different from a blood group A or B, because there are less recipients on that blood group waiting for an organ. And there are, even though there are less donors with that blood group. And is it a genetic reason that make them harder? I guess that the genetic reason means probably liver disease. I'm not quite sure what is the genetic reason question here means, but if it alludes to the type of liver disease, yes, there are some genetic liver disease that make harder access to transplant just because their score does not reflect how sick they are and how badly they need a liver transplantation.
Terrific. So we'll answer all of the questions that's submitted via Slido, and we'll also send a link to everybody who's registered. And I'll turn it over to you, Nazia, for concluding remarks.
Well, again, thank you very much to all our panelists this morning for their excellent presentation. I personally learned so much from every single one of you, and I hope that we are able to put all this information together and be able to address the access to liver transplant, and have hopefully next year around this time some more information and steps that we have taken to address this disparity or access to transplant. I also want to thank all the people who are listening to us through YouTube today. And all the people, obviously, all the people who have submitted a question. I'm sorry that we ran a little bit out of time and we weren't able to address all of them. I promise we answer all through this Slido. And also, I would like to take a moment to ask everybody to look at the program for this week and try to tune into various events. Tomorrow we have an amazing event celebrating the living organ donations, and please join us for that event. And throughout the whole week, there are various activities that is organized by the center. And thank you again, everybody, for joining us this morning.
Hi everyone, and thank you for joining me. My name is Christy, and I'm going to be guiding you through a short yoga practice. So we're gonna practice for about 15 minutes. It's gonna be really relaxing. We're staying on our mat. We're not gonna be doing any standing postures. So this is really good if your muscles just need a good stretch, if you just want a few minutes for yourself to relax, to unwind. Again, no experience necessary. Just do what you can. I'll provide some modifications, have some water handy. And the biggest thing I can tell you is let go of any judgment towards yourself, towards your body, your mind, your breath, anything. Just let all of that go and dedicate the next 15 minutes to your body and your mind. So you can start either laying down or sitting up. If you are sitting up, you want to sit up nice and tall. Try to lift up through the spine, drawing the crown of the head towards the ceiling. If you're laying down, you're just going to lay down in a really nice, comfortable position where you're able to relax and just start to close your eyes. And for the next few moments, just begin to bring your awareness to your breath. I don't want you to change the way that you're breathing, just the natural rhythm of your breath. Just begin to notice the rise and fall of your chest and your belly with each inhale and each exhale. And with your next few exhales, see if you can allow yourself to deepen, whether you're laying down, see if you can sink a little bit further into the mat. And if you're sitting, see if you can get your sit bones to sink down a little bit further. Let your shoulders soften. Allow your tongue to fall away from the roof of your mouth. And just release the biting surfaces of your teeth, relaxing your jaw. And soften the space between your eyebrows. And we're going to start our yoga breath now. So our yoga breath, we breathe in and out through the nose. So in through the nose. Feel your belly rise and exhale through the nose also. Try to breathe through the belly, so as you breathe in, feel your belly start to blow up like a balloon. And then exhale, let your chest go, and then your belly will deflate last. So our breath is a very important part of our meditation practice. So we're going to try just a 1-minute meditation, and all I want you to do is to just count your breath. Breathe in for 5, so 5, 4, 3, 2, 1, and let's breathe out for 7. So 7, 6, 5, 4, 3, 2, 1. Very good. So the next 3 breaths I want you to do all on your own, breathing in through the nose for 5 seconds and out through the nose for 7. You can count out loud or you can count in your head. We're just going to start to train our brain to just focus on the breath. Good, and we'll begin to just draw our awareness back to the present. Start to wiggle your fingers and your toes. Circle your wrists, and if you're laying down, you can start to circle your ankles, just starting to get some gentle movement back into our body. Very softly start to open your eyes, move your neck from side to side. Good, so if you're laying down, you're going to stay there. If you're sitting, we're going to come all the way down to our mats. First, we're just going to give our hamstrings a little bit of a stretch. So first things first, shoulders nice and soft. Try not to tense those up. And then second, you're going to tilt your pelvis down so that your hips are nicely rooted into the mat. And we'll start by extending that right leg all the way down. And then just letting that left leg go. So if your hamstrings are really tight, bend this right knee and have your right foot flat. You see how that makes a difference? So again, if your hamstrings are really tight, you can hold on to the back of your leg and just ease in here. So if you are a regular practice, if you regularly practice yoga or Pilates or any other exercises, maybe your hamstrings are nice and loose, which is beautiful. You're still going to get some benefit out of the stretch, but we're going to try and take it a little bit further for you. So if your hamstrings are really loose and doing this doesn't feel like much, you can release this right leg and you can start to flex your toes towards your face, pressing out through that heel. Try to keep your shoulders nice and soft and your face nice and relaxed. So we're just going to breathe here, inhaling through the nose. And exhale through the nose. So keep pressing out through the heel if your body will allow you. If not, again, no judgment. We're still getting a nice, beautiful stretch here. One more breath. Inhale through the nose. And then exhale. Hug that knee into your chest. Grab onto the top of your knees with both, the top of your left knee with both hands. You can interlace your fingers here. Let that right leg drop all the way down. Okay, so we're going to start to stretch our hips. So very gently, keeping both hips rooted down, start to draw this left knee into your chest. So let this left ankle just hang out. You don't want to tense that up too much. Again, face nice and tense, shoulders nice and soft. Just focus on moving with your breath. Forget about the movement here. Taking 2 breaths, and on your exhale, as you create some space in your body, see if you can draw that left knee a little bit closer. And if you can, maybe drawing that towards your left side armpit or the left side ribs. One more breath. Nice deep exhale. Again, through the nose. Beautiful. We're going to release that left foot, bending that left knee, bringing your right knee into our chest, and then extending your right leg. So moving on to the hamstring stretch for the right side. So again, if your hamstrings are really tight, you can bend this left knee, placing your left foot on the floor, or keep that left leg fully extended. That's up to you. So again, you can place your hands behind your thigh if you wish. Try to keep both hips rooted down, shoulders nice and soft. We're just going to breathe through this. And if you want to add a little bit more, again, listen to your body here. So if it feels like it's a little bit too much, then just stay here, or you can lower your leg a little bit. It's up to you. So if you want to flex that toe, flex those toes, start to press out through the heel. Again, if it's too much, then don't do this. Just enjoy the nice stretch. Good, 2 more breaths here. Okay, 1 more. Beautiful. Bring that right knee into your chest. Hug it. Let that left leg come all the way down to the floor. Again, settle those hips. Soften your shoulders. Inhale through the nose. And exhale, drawing that right knee a little bit closer if you can. Again, no judgment, no shame towards yourself, your body, especially if this is the first time you've really had movement or stretched in a little while. 1 more. Maybe this time bringing it towards your right side armpit, down those right ribs, right side ribs. Good. 1 more breath. Beautiful. We're going to make our way up to the mat. So you can bring your knees into your chest and rock and roll all the way up. And here we're going to give our hips some love. So what I want you to do is bring the soles of your feet together. So if your hips are really tight, women especially generally have tighter hips than men do. So if this does not feel good at all, you can try moving your feet farther away from you. So creating more of a diamond shape with your legs. And if you still feel a nice stretch there, then that's where I want you to stay. But I want you to come where you're first feeling that nice stretch. So discomfort is okay, but if it's painful, again, move your feet farther away from you. So sitting up nice and tall, Just try and elongate the spine, soften those shoulders. You can grab onto your feet, grab onto your ankles, grab onto your knees, whatever is comfortable for you. We're just gonna sit here for about 30 seconds. And again, just moving with your breath, trying to breathe in and out through the nose. And if you have a hard time, you're feeling distracted, you know, you saw a squirrel or your dog's barking or your kids are making noise, I want you to just focus on counting that breath. Again, 5 seconds in, 7 seconds out. And you can use this practice in daily life. Spend 5 minutes or even 1 minute every day when you get a chance to just sit and be and practice your breath and practice allowing your mind to just drift. We're going to add a little bit of a stretch for our spine here. If you'd like, what you're going to do is take a nice big inhale through the nose. And as you exhale, I want you to start to round forward. So start to fold from the hips, and then you can just allow your shoulders to round forward, rounding through the spine. So again, there's nothing saying you have to reach the floor. You can keep your elbows here. Just allow your spine a little bit of time to decompress. Good, let those shoulders get nice and soft, and if your jaw is tensed up, just try and soften that again. Just allow that tongue to fall from the roof of your mouth. Feeling this nice stretch in your hips and then giving your back some love. One more breath here. Inhale and exhale. Come all the way up, and now we're going to make our way onto all fours. So we're coming into our cat-cow. So 2 poses we combine into one, really great for the back and for the hips. So you want your knees shoulder width apart, hands spread directly under your shoulders, nice and wide fingertips. We're gonna start by inhale, tilt your pelvis towards the ceiling and let your belly drop. This is our cow pose. Moving with your breath as you exhale, scoop your tailbone under, begin to arch through the back, press the floor away, head down towards your belly. This is your cat pose. Inhale, so tilting that pelvis, let that belly drop. Look up or just forward. Exhale, again, scoop your tailbone, round out through the spine, head down last. Each movement starts with the hips. One more time, inhale for your cow pose, and exhale for your cat. Good. Good, come back to a neutral spine, and we're gonna come into our child's pose. So your feet can be together or apart. You're gonna sink down towards your heels. So feet together if you have really tight hips. If your hips are a little bit loose, you can widen them. And here, this is the beauty of this pose. Just start to crawl your hands forward and rest your forehead down on the mat. So if it's more comfortable, you can rest on one ear or the other. And here, I just want you to let your body go. So move from the top of your head all the way down to your tippy toes and just start to soften every muscle and try and sink into the mat. This is a great pose. We're not going to spend a lot of time in it today because we only have 15 minutes and we're almost finished. This is a great pose if you just need to unwind. Even if it's just for 1 minute, 30 seconds. It feels so good. Normally we end our practice with a Shavasana. Today it's going to be very short, but I encourage you, if you are interested in this practice, to check out a local studio. A lot of studios are reopening, or there's lots and tons of videos online for you to enjoy. So you're going to come back into your tabletop pose. From here, swing your legs out to either side. Come to rest on your bum and all the way down on your back. We'll spend 1 minute here. And again, feet apart, let your feet fall, arms by your side, palms facing up. eyes closed. And start to count that breath, inhaling for 5 seconds and exhaling for 7. We'll spend one more moment here. And here I want you to start to thank yourself, thank your body for practicing, for moving, for taking the time out for yourself, even if it wasn't a lot. You start each day with a moment or two of gratitude, and then eventually start to build up to longer meditation practice, longer yoga practice, whatever it is that you practice for yourself. Just allow yourself some time every day to do that. And we'll start to bring some awareness back, wiggle our fingers and our toes, circling out the wrists and ankles. Rock your neck from side to side. Good, bring both knees into your chest. Let's give ourselves a nice big hug here. Shoulders dropped. And then we will make our way all the way up to a seated position. So join me in a seated position. We'll end our practice sitting up nice and tall in a comfortable position. It can be cross-legged, it doesn't have to be. Arms by your side or on your knees, just nice and comfortable. Again, relax your face. We'll inhale and sweep both arms overhead. As you exhale, bring your hands down to your heart center or down to prayer. The goodness, the light, the love inside of me honors that same goodness, light, and love inside all of you. Namaste, everyone.
Hi, good afternoon, everybody. My name is Joanne Z, and I'm the Senior Clinical Director for the Transplant Program at University Health Network. Thanks for joining us today. So you're joining your Nutrition Questions Answered session, and we have a very distinguished panel with us today. But before I hand it over to our panel to introduce themselves, just wanted to go a little bit over the logistics. So today, if you want to submit questions, please log into Slido, hashtag LU stands for lunch, 2, LU2. So thanks very much again. And we're really excited. This is an important topic. We know that food matters, and diet and safety and how it relates to transplant is really, really important. So we're so thrilled to have this panel with us. So I'm going to start off. If Diana, you could introduce yourself.
Hi, my name is Diana Major. I'm an associate professor of clinical nutrition at the University of Alberta and a clinical pediatric dietitian who's worked for years in pediatric hepatology pre and post transplant. My research program also focuses on the impact of nutrition on liver health.
Thanks again for joining us.
Thank you.
Mandy.
Hello, hi, my name is Mandy, and I'm one of the transplant dietitian working in the multi-organ transplant program at the Toronto General Hospital. So I work with patients who are admitted to the hospital when they're very sick in their end-stage disease and requiring transplant, and also help with post-transplant patients to help with their recovery after their surgery. So I work mostly with lung and liver transplant, and also patients who require both the kidney and pancreas transplant. We have another dietitian who works with only kidney transplant, but unfortunately she isn't able to join us today. So I'll try my best to answer any questions that you may have.
Great. Thank you so much. And last but not least on our panel is Kalina.
Hi, my name is Kalina Yim, and I'm a nurse practitioner working here at the Toronto Centre for Liver Disease in the liver clinic. So my clinical focus is on viral hepatitis, and meaning that I see a lot of patients with hepatitis B and C. And I also look after a subgroup of patients who are very sick, who have end-stage liver disease requiring paracentesis. So I do have a spectrum, like patients with a spectrum disease, meaning from someone who have inactive liver disease to someone who have the end-stage liver disease. So I must add that I've been working here in the liver clinic for 30 years. So I do have seen a lot of patients. And because of my language skills, also because of my specialty in hepatitis B, I do see a lot of ethnic Chinese in my practice. So I think that I can maybe speak about like some ethnic considerations if some people have some questions. And yeah, that's all.
That's great. Thanks, Kalina. So as you can see today, we've got this very incredible, experienced, distinguished panel. So I think it's going to be an exciting hour that we're going to learn lots and be able to pose questions. So again, slido.com, hashtag LU2 to submit your questions. Just a reminder, today's session is being recorded and will be available in the Center of Living Donations YouTube channel. And if you did register with Everbright, you'll also receive a follow-up email. So, all right, let's start with a question. And I wanted to start off with a real general question. As we know, UHN is an academic hospital working with various universities and organizations. And we pose the question, what does the research tell us about the link between food and liver or kidney health? So what's the latest research telling us? Why don't I start off with Diana?
So there's a lot of new emerging research related to liver disease and food. Certainly in the area of non-alcoholic fatty liver disease, there's lots of evidence, for example, that shows that eating a diet that is focused on fruits and vegetables can really be healthy in terms of limiting the amount of fat, extra fat you store in your liver. So that's really important, especially for individuals with milder liver diseases. When you go to the spectrum of more serious liver disease that both Colina and Mandy have lots of experience with, and so do I. And then some important things to think about what the literature shows is, for example, the quality of the type of fat that you eat. Long-chain polyunsaturated fatty acids are really great in terms of promoting anti-inflammatory properties in the liver. It's important to avoid fasting for patients with end-stage liver failure in order to keep your blood sugar in the healthy reference ranges. So eating smaller meals that are calorically dense, that have high sources of protein in them are important, because there are some amino acids, for example, that can help build up your muscles as well. And so those are all areas that are really interesting to me in terms of trying to promote liver health in adults with liver disease. Mandy, I'm sure you have lots more to add.
I had a question, actually, if that's okay. Just you mentioned vegetables and fruits. Does it matter if it's raw versus cooked? Does that affect the nutrition level?
If you boil, for example, vegetables for a long period of time, you can lose some of the B vitamins in the water. So lots of boiling probably will reduce the nutrient impact of those, but steaming is fine, or perhaps even microwaving. It's really more about looking at, I always say, make your plate shimmer. The new Canada's Food Guide really emphasizes green, red, orange, and yellow vegetables, and you really want your plate to pop. And that's especially important with non-alcoholic fatty liver disease as well, because those have lots of antioxidants in them, and that helps fight against inflammation in that kind of condition.
Great, thanks.
Can I just sort of project here for a point that you just talked about, that like cooked vegetables, like, you know, in ethnic Chinese diet.
Sure.
They don't, I guess, like including myself, I'm not a particular in favor of raw vegetables. So a lot of, I mean, we steam all our vegetables.
Yeah.
Steaming, but also boiling. So actually, I understand about this, like, you know, destroying of nutrients if you're boiling for too long. So what I usually educate my patient is, yes, you can boil it, but don't boil it for too long.
Mm-hmm.
Like, so that is like broccoli. I mean, a lot of ethnic Chinese, they don't eat raw broccolis, right? Versus Westerners.
But they eat steamed broccoli, right?
Yes.
In the stir fry.
And stir fry. So I always have to remind them, don't stir fry them too well, like, you know, so that you don't lose too much of the nutrients. And again, another point that you talk about, avoid fasting. I think that is very important, especially in the advanced liver disease patient group, right? So I see that a lot when people have the complication of ascites, when their belly is so full of acidic fluid, because they don't have the appetite, they don't want to eat. And that is the time that when they start losing a lot of muscles, right? That is the appetite issue. Yeah.
And also because, you know, in the fasted state, they'll utilize their lean body mass stores for energy to keep their blood sugars in the normal reference ranges. And that's not a good thing either. If you're depleting your skeletal muscle mass, you become very frail, and that's been associated with increased morbidity and mortality as well. So late evening snacks that are small but can be compact. And for example, you could eat like rice and put a little bit of meat in there as well, if that's what you like to eat. So rice balls, for example, in China are often with a little bit of pork, for example, if you eat pork, are often a late evening snack that's recommended to patients with end-stage liver failure. So I agree with that totally.
Yeah, I agree. From a transplant perspective, malnutrition is very common among my patients with end-stage liver disease. So the main goal for end-stage liver disease before transplant is to avoid the weight loss, maintain their muscle mass by eating small frequent meals. We usually order a nighttime snack for them, including a protein and a carbs. Sometimes even a nutritional supplement drink at nighttime may be helpful too. Yeah.
Great. Thank you. I think that really highlights some of the latest kind of research and how we can link food and nutrition to healthier outcomes. So thank you.
Mandy, can I just, sorry to interrupt again. So talking about the latest, I just want, I'm not sure whether Diana would be talking about, I want to talk about the relationship of coffee and the liver. So, because there are so many research now on the benefits of coffee for the liver. So one of my pet peeves now, when patient tell me that, oh, I spent like, this amount of money on buying all the herbal supplements, I said, no, go for coffee. But of course, we still have to be cautious that we don't want patients to take a double in their coffee. But we definitely, like, coffee has been proven to be good for the liver. It can lower your liver enzymes. You can even prevent liver cancer. But in general, it is better, I would say, a supplement than any of those that, you see on the shelf, like liver cleansing tablets or things like that. So,
and I agree with that. The only concern I have is that we have to be cautious about how much coffee, so that you don't displace what little food you do eat too, right? So sure, I think we have to balance it, because coffee doesn't have any protein in it. Yeah. And while I agree with you, the literature shows that we want to make sure they don't displace how much of those nutrient dense snacks when they have end stage liver failure, because it's hard enough to maintain lean body mass. So I agree with you.
Yeah. Thank you. I think a lot of us like our caffeine. And so when you talk about moderation, is it, is there an amount that you would recommend? 1 cup a day, 2 cup a day? What's too much?
Well, I think the range of caffeine, it depends on the type of coffee you do drink, right? And in terms of the milligrams of coffee, but usually we don't say much more than 2 cups of coffee a day. We're not talking about 5 or 6 cups of coffee, because you for sure will interfere with your oral intake and displace your nutrients. But 1 or 2 cups of coffee a day are perfectly fine, and may even be beneficial. I don't think we know the exact amount of caffeine, but there's different brand names of those commercial coffee outlets, and some have a higher concentration of caffeine in them than others do. So
yeah, no, I agree. So it's we tell our patients, like, so a lot of patients are concerned, right? It's like, oh, I have liver problem, I cannot take any caffeine. So I said, well, no, you can take, like, up to 2 cups a day is absolutely fine. As like, Diana mentioned about this, make sure that it's not displacing your other protein intake and your food intake. It is fine. And we also know that from research, taking the percolated coffee is better than the instant coffee. That's not as much caffeine in the instant coffee. And also, the study have done compare coffee and tea. So coffee is better than green tea as well. So it's just something like, so that you can be so comfortably taking 1 to 2 cups of coffee per day.
Yeah. Okay, perfect. Yeah, I was just going to ask the question around, I know individuals who may not like coffee, is there an alternative to tea or, soda, caffeine soda? No. Okay.
No.
All right. Thank you. The next question I'm going to segue into is a real question that we get a lot of, and it's around that balance of taste and the food profile compared to what's safe and what's not safe. So food safety is a big question that we get, and often we talk about raw fish. Sushi is one question. How do you define healthy eating, and what are some do's and don'ts of safety, and how do you mix that with flavor, variety, and living a good quality of life? So maybe we should start off. Who wants to take that one? Diana?
I'll start, but I think actually Mandy would probably have a lot to say about that. I mean, certainly we do have to be concerned about microbial content in foods like sushi. And so for post-transplant, we do tend to recommend to avoid that. I mean, I'm all for food tasting great. So using a variety of spices is a great idea. You have to be careful about salt though, right? For when you have end-stage liver problems, salt can worsen ascites and make things worse. So there are lots of other ways to taste up your food by adding lemon. There are salt substitutes, but you have to be wary of them if you have kidney problems and problems with high potassium levels. So but there are lots of other spices that taste really good, like ginger, for example. Fresh garlic can be added to food too, to give it, depending on your cultural preferences of adding things to the food to make it tasty. I mean, Mandy, what would you suggest?
I'll comment about the post-transplant piece then. So
Yeah.
when you're taking the anti-rejection medication after your transplant, your body's immune system will be weaker. So food safety is very important to prevent food poisoning or any food-related illness. So it's very important to wash your hand before preparing any foods. Make sure foods such as meat, poultry, seafood, eggs are well cooked. Dairy items and fruit juice should be pasteurized. Salad should be very well washed at home. I usually suggest my patients to avoid salads when eating out because you're not sure how well they wash the salad. So I would suggest having salads at home would be much safer. We have a booklet from Health Canada. We usually use this booklet to teach our patients before they leave the hospital. It has a really good chart that talks about what foods are safe and the internal food temperature. So if you're interested, I can let you guys know about the link to find this booklet. And you can also Google it from Health Canada. You can always find this booklet there.
I think we can probably send it out and maybe post it in somewhere that people could link onto that. That'd be great. Thank you so much.
Can I ask Mandy a question?
Yeah.
So it's not that I advocate people to go out to restaurant and eat, but I know that like when we go to a restaurant and we have leftovers, we always like to take the leftovers home and eat it other day. So how safe is it? Because I do have patients ask me. I personally, when I take food home, then I would try to eat it within the next day. But is this safe? Or would you recommend to just put the leftover in the freezer? I mean, like, you know, what we should do with the leftovers.
Well,
or maybe we should not take the leftover home.
Well, definitely take the leftover home. I don't suggest wasting food. If you go home right away, store it in the fridge below 4 Celsius, and then make sure before you eat it, reheat it very well. Make sure that it's heated throughout. So that should be safe to reheat the food. Yeah.
That's great. Thank you for that suggestion. So I'm wondering if we should turn to Slido and look at questions from our audience. Okay. So why don't we go with the first question, which is it recommended to have a low protein diet post-kidney transplant? Is it necessary for protein to be plant-based? Do we want Mandy? Do you want to take that?
Sure. So usually in the first 6 to 8 weeks after your transplant surgery, it's usually recommended to increase your protein and calorie intake to help with the healing after your surgery. Because during your hospital stay, you may not have eaten well and you may have lost some protein during surgery. So it's recommended to choose high quality proteins such as chicken, turkey, fish, lean meat, eggs, and also plant-based protein too. But it's your personal choice to have meat or plant-based protein. But plant-based protein does have higher fiber content and no saturated fat. But one thing to consider is that it's your blood work, because some individual may have increased potassium from your transplant medication. So your healthcare team will monitor your lab work closely and will let you know if you need to limit any high potassium or phosphorus based on your lab work.
Thank you. Now, is this different from a liver perspective? Because this question was specific.
It's the same for liver as well. The team will monitor your blood work as well. And because I do see patients post liver transplant, and some of them may have high potassium as well. So they sometimes need potassium restriction. Yeah.
Does anyone else from the panel have anything else to add before we go?
Just wanted to add it's very important to look at the if you use like salt substitutes or other allspices, to make sure that you check on whether or not that contains potassium, because there are a lot of salt substitutes and ultra processed foods that contain a lot of potassium in them and can be big contributors to elevated potassium as well in the diet. So that's something really to think about. Definitely plant-based proteins are very healthy choices in terms of longitudinal longitudinal like high lipids and so forth. But as Mandy said, I do think that animal-based proteins are high-quality proteins, and they should be also encouraged, but based on personal preference of what someone wants to eat. And from a liver perspective, because patients have had loss of lean body mass pre-transplant, it's also important for them to eat a high-quality protein and sufficient protein in order to help maintain what lean body mass they have as well, because that's going to be a ongoing issue if you eat a low-protein diet. And you don't need to, if your organ is working post-transplant, then you should be eating a protein-focused diet.
Great, thank you. All right, our next attendee, Len Hodder, thank you for submitting this question. And my background is rehabilitation, and I always think of, prehab. So before surgery, we'll ask the question, for a living kidney donor, is there an optimal diet for the months leading up to the surgery to be in the best condition for donation and recovery, and then long-term afterwards, living with one kidney? Let's see who can take that one. Shall we have Mandy?
Sure, yes, I can address that. So prior to kidney donation or any other surgery, so it is very important to have optimal nutrition, including adequate calories and protein, to help with the recovery post-surgery as well. So it's recommended to follow the Canada's Food Guide, eating a well-balanced diet, including complex carbs, protein, vegetables, and fruits, and dairy. But in the long term, post-kidney donation, it's important to maintain a healthy, balanced diet as well, as your kidney is able to perform the same function. Yeah.
Great. Anyone else, anything to add to that?
So I think Mandy said it very well.
I agree.
Great, thank you. The next question. So for patients who are pre-dialysis, do you have tricks to decrease sodium consumption while making food taste delicious? Ideas for low sodium snacks. I keep watching I keep watching Food Channel, and some chefs always say, double the salt to give more flavor. So any ideas around this one?
Well, I love lemon juice to add to food. I really think that really zests it up a little bit, and lime juice for certain foods too. And you can use other spices, right? There's a variety of other spices that in different ethnic cuisines, such as paprika, for example, and some European ethnic cuisines really can give foods like chicken and potatoes a zest that you wouldn't expect. And so it is hard to switch. If you're used to adding it at the table, your very first good step to dealing with this is to stop adding it to your food first before you make other changes, and maybe try some of these other alternatives. There are other like Mr. Dash type things, but again, if you have elevated serum potassium, as Mandy indicated in other questions, that could be an issue and contributing to it. But I mean, I'm sure Colina and Mandy have lots of other good tips too.
I personally I love black pepper, and that is the spice that I put in a lot of my food. What I found too is I sort of adopted from the Vietnamese cuisine, and that is what I recommend my patients try lemongrass and lime. It's beautiful, it tastes, yes, yeah. And also, as you, Diana, you said other spices in the different ethnic group, like in Chinese, there's some spices, the 5 flower spice, and so I mean, try to explore, because everyone's taste is different. So I cannot say, wow, this is good, but just have to be mindful though when you pick up spices from supermarket, and make sure you look at the content though, because sometimes they are pre-mixed and there's so much already mixed in the spices itself. It's not pure, and there are sodium content in it. So it's just to be mindful it's just make sure every time look at the labels when you shop.
Thank you. The second part of the question is really interesting around, do you have ideas for low sodium snacks? I think of in my desk, I probably have a couple of bags of chips for those emergency snacks in the middle of the day. Do you have any ideas around low sodium snacks?
Well, I happen to love baked like zucchinis, and I always keep veggies in my drawers because I've got smaller kids, and when they come to visit in the office before COVID, to make sure that I have those kind of snacks. You can bake different vegetables with just a little bit of olive oil and make them crispy, and so almost like make your own chips, but very low on the oil, and then you don't have any extra sodium with that. So kale is great like that. My grad students used to bake me kale chips with a little bit of olive oil. You just put it on a baking tray in the oven, and we would have a snack of crispy kale, and it actually changes the whole flavor of kale. You need new kale though, not older kale, because that could be a little bit bitter. So I like those kind of snacks. They give you that crispy feeling without adding any extra sodium.
Yeah, sounds delicious. I think we scheduled this session during lunchtime, noon, and it's making everyone probably listening a bit hungry. Any other ideas for low sodium snacks from others?
My rule of thumb is always have a protein with a starch when it comes to snack. So no salt added nuts with crackers would be a good snack. Even a slice of bread with peanut butter can be a very simple snack. Yogurt with fruits can be a very simple snack that you can usually have at home. Yeah.
Great.
Yeah, that's what I usually recommend to patients as well, is those no added salt nuts, like walnuts. Just buy the fresh ones and crack up the shells and then eat it fresh, and no salt added other cashews and things like that. I personally like sesame snap. I don't know, of course, I feel it's kind of sweet, but that is my favorite snack, is the sesame snap. So maybe here the dietitians can advise me, is that a good snack or not?
It sounds delicious. All right. Well, thank you for answering those questions and your personal favorite snacks. So the next question is, post-transplant patients can become diabetic. What diet should one follow to try to prevent this?
So I'll address this question.
Oh, fantastic.
Yeah, so some people may develop diabetes as a side effect from their steroid medication called prednisone. You can manage the side effect by limiting foods that are a concentrated source of sugar and following a balanced eating pattern. Sugar and sweets, such as sugar, regular pop, fruit juice, dessert, cakes, pastry, I would suggest usually to try to limit, and if possible, and if approved by your transplant team, adding some exercise would be a great idea to help manage blood sugar.
That's great. Anyone else with anything to add on that one?
Just that if you do have a sweet tooth, you could use a sugar substitute. You could even try baking some muffins that are made with whole wheat flour. They could be a corn-based muffin. It'll give you that feeling of having a little bit of a sugary food, but it's not actually sugary, right? Because it's a more complex carbohydrate. So be creative about making different types of muffins, but make sure that these are muffins that are using whole wheat flours and a limited amount of added sugar to the recipe, so that you can get a bit of a zip flavor. Add cranberries to muffins as well, and cut the sugar content in that muffin recipe in half, because cranberries or blueberries are naturally occurring sugars, and that they can give you that sense of sweetness without actually increasing your burden of simple sugars.
That's a great tip. Thank you. Just speaking of diets, I'm going to get off topic a little bit from Slido, but we hear a lot about trend diets, and I think the latest one has been about fasting. Depending on your age, how long should you fast for? I'm just wondering the research around that and how that impacts transplant recipients as well as donors, what your thoughts around that are. I think Diana, you might have, or Mandy?
Sure.
Yeah.
So it is really popular. Lots of people want to, for weight loss, want to eat diets where they prolong their food intake. I mean, we all fast overnight for 12 hours, and that's fine. But if you're talking about long-term intermittent fasting, where you go more than 16 or 18 hours a day, that's not really actually the best way for liver health in particular, because you really do end up eating more calories or displacing your energy intake. And moreover, with end-stage liver disease, I would actually say an intermittent fasting approach is not healthy for the patient at all, because of the reasons we mentioned before. Patients with end-stage liver failure typically have elevated energy expenditure. They need more calories, but they also should not go for prolonged periods of time in terms of their liver health. So that's not a great idea, because they'll utilize their lean body mass, as I mentioned before. So intermittent fasting is really not the best approach for nutrition and liver health in the end-stage liver processes. And it's not the best choice even for a non-alcoholic fatty liver disease, mild disease as well. In terms of substrate and the way you change the way substrates are used in the body, it's not really the healthiest approach either. If you're talking about just keeping your hours of eating for someone with mild liver disease like NAFLD in an 8 to 10 hour period, and in extending your overnight fast to 12 or 14 hours, I think that could be a way to help you monitor how much you're eating, and that would be fine. But any longer than that really isn't doing yourself any favor, because you really will go to using your lean body mass for energy, and then that just slows down your energy metabolism even more. They're also popular because they talk about ketogenic diets, like let's eat, not only do intermittent fasting, but let's do that with a very low carbohydrate intake, because then you can mobilize fat stores. And that's a popular weight loss strategy that people have been employing. And you can get short-term weight loss for sure with that approach, but it's not really been proven whether that's optimal for your liver health either. And a lot of what you're losing in the short term is fluid and lean body mass with those approaches. So you have to be careful. People like those diets because if you eat a very low carbohydrate diet, you build up ketone bodies in your body and you don't feel as hungry. And that's one of the reasons why you keep hearing about those intermittent ketogenic type diets in the media. Not a good idea for anybody with end-stage liver failure. And post-transplant, I'm going to let Mandy comment on those.
In terms of post-transplant, we don't usually recommend fasting because with post-transplant, you do need enough calories and protein to help with the healing post-surgery. And also we do recommend, let's say transplantation who are on anti-rejection medication are at a higher risk of getting diabetes. So fasting would be a dangerous option. Let's say if you're on any insulin or any diabetic meds.
Thank you. I think all these different diets that pop up and claim success, I think it's really good to kind of relate how that impacts transplant and liver and kidney function post-operatively. So thank you so much. I just wanted to say one of our attendees also passed on a website. For those viewers, www.myspiceit.up.ca has a wealth of delicious low sodium recipes for renal patients. Anyone looking for a low sodium, potassium, and phosphorus food option. So thank you very much to our viewers who sent that in. If we go to the next question, leg cramps. We know that can be so painful and disruptive. So it can be a result of low magnesium and the foods that this individual is consuming doesn't seem to be helping. So what would you recommend that would be easy to digest? Would this be a Mandy and question potentially?
So magnesium foods, legumes, nuts, seeds, fish, leafy greens are good source of magnesium. So if your potassium and phosphorus levels are okay, I would usually suggest you increase the intake of pumpkin or squash seeds, nuts, and sunflower seeds. For example, a quarter cup of pumpkin seeds provide about 300 milligrams of magnesium already. So if the level remains low, you may need to consult your transplant team to see which medication or which supplement may be appropriate for you.
Great. Thank you. Yeah, it's such a delicate balance to make sure, individual changes can really impact the overall outcome. So it is important to speak with your healthcare provider and team on that. So thank you. Next question. Do you recommend a person with liver disease do an over-the-counter detox? If not, is there a certain kind of food that will detox and remove fat in the liver? Who wants to take that one?
Wow, I actually don't
Diana,
recommend a detox formulation for the liver. If you would like to help your liver not have as much fat, then I can tell you things to eat, like fresh, healthy fruits and vegetables, to reduce your amount of extra fat in your diet, particularly saturated fat. So make sure you eat lean cuts of meat. If you eat a lot of saturated fat and a lot of foods with added sugars, like sugar sweetened beverages, carbonated beverages, cakes, cookies, or whatever, that actually builds up causes your pancreas to secrete more insulin, and that insulin stimulates fat production in the liver. And so the best way to not speed up fat production in the liver is to reduce the amount of intake of those types of foods. And if you follow Canada's food guide, again, coming back to that plate with shimmering with fruits and vegetables, whole grains, and your plant proteins, and making sure that they are lean cuts of meat when you do eat meat, that's the best way to reduce the rate of fat production in your liver. And if you reduce the rate of fat production, eventually you can reduce the amount of fat in your liver, particularly in the early stages, for example, of non-alcoholic fatty liver disease. So over-the-counter detox remedies that make promises about your liver health some of them could actually be harmful for your liver. So that's my viewpoint about that. Colina, you might have something to suggest as well.
I think you have said it beautifully about what to be mindful of what you eat when you have fat in the liver. So I guess what I would like to add though is there's really no magic bullet in getting rid of fat in the liver. So right now we do have clinical trials, like medications that would help with fatty liver, but again, these are really early trials and they are not approved or anything. So the mainstay of treatment for fat in the liver right now is healthy eating, as Diana suggested, and also regular exercise. That's really the best intervention. Another thing I like to add is a lot of time, fatty liver is closely associated with diabetes and high cholesterol. So just to make sure that you have your blood sugar and your cholesterol check and your lipids check, and to make sure that they're not at excessive level, or if you are already taking those medications, just to make sure that they are well controlled, because if the diabetes and cholesterol, they're not well controlled, it can very well give you fatty liver as well.
I agree.
That's great. All right. Thank you. Now, this next one is specific, but it's a great important question. So sometimes the gallbladder removal is part of transplant. Is there anything special around the diet recommendations that you would have for that? Anyone want to take that one? Mandy?
I can address, yeah. So for gallbladder removal, so usually gallbladder is where we store the bile to help digest fats. So even with or without gallbladder, post-transplant, we usually recommend people to avoid a very high fat diet, because when you're on that anti-rejection meds, it can have a side effect to raise your cholesterol level, and also side effects of weight gain as well. So I would suggest to continue to follow a moderation fat diet. Don't have too much of the saturated fat overall. So Yeah, so even with the gallbladder removed, it's the same diet that we would suggest to post-transplant patients. Yeah.
Great. Thank you. So the next couple of questions from our audience relate to supplements. And so the first question is around someone with liver disease having difficulty eating enough protein. Is a protein supplement like Pro-T, Gold liquid protein shot okay?
Well, I don't think I can answer because I don't know what it is. So maybe Diana, you can help with this question.
So honestly, I haven't had experience with this, so I looked it up. I'm just going to be honest, just to see if I could see what the nutrient content was. And it looks like it's about 1 ounce has 17 grams of protein in it. It's a collagen-based protein from what I could tell. The only concern I had about it is that it was difficult for me to tell if that was a nutrient, like a complete mixture of all the essential amino acids in that formulation. So I'm not really sure because I'm not familiar with that exact product. The concept of taking a protein supplement, though, for example, in other commercial products where we do know the amino acid profile is complete, there are a variety of brand names out there like Ensure or Boost. It's perfectly okay to drink to supplement your diet with those foods. The only caution I have again is you don't want to displace your oral intake with the use of those supplements. So so long as you still are eating your small frequent meals, if you want to take that supplement with it, make sure you take it with some carbohydrate, because from what I could tell in this product that it was carbohydrate free. So you'd really want to make sure that if you're going to drink this, take it with some crackers, or like Mandy mentioned before, maybe some bread, maybe take it with another protein source like peanut butter if that's what you like. And I could not tell if there was a do harm associated with this. I don't think so. But because I'm not very familiar with it, I do think that it's important to give a comprehensive answer for me to look at the details in more detail.
Great. I think that's just really important advice in general around supplements as a whole. It sounds like, really working with your healthcare provider to review the actual makeup of that supplement, because one product is not equal to another.
That's right.
Great.
Yeah, I think I would add that is supplements and all the herbal remedies as well. And in fact, many like herbals, they're actually toxic for the liver. So we have to really be careful not to take anything, casually.
Yeah, such valuable advice, because sometimes those labels and at the back of supplements, it's a lot of information, and how you tease that out, the professional to work with your clinician. So thank you. The next supplement was around omega-3. Is it okay to take that after transplant? Who wants to start with that one?
In terms of omega-3 supplements after transplant, because there's a lot of different source of the supplements, let's say from fish liver oil, or from different source, I would suggest that when you're on all the anti-rejection meds, it's very important to let your team know, your healthcare provider know, your pharmacist know if it's okay to take this omega-3 supplements. Omega-3, if you obtain it from fish or any food source, that would be totally fine. But if you're considering any supplements, I would suggest that you take it back to the team and see if that's okay with all your other medications.
Thank you. Anyone else with anything to add on that one before we go to the next?
Just from a NAFLD point of view, there is some evidence, it's not really strong, but there's some evidence that omega-3 supplementation can be helpful in terms of promoting anti-inflammatory properties in the liver. It's not a specifically recommended strategy to help with fat buildup in the liver. There's certainly for lipid clearance, for example, with patients that have high lipids, there is evidence that omega-3s can help facilitate lipid clearance. But I agree with Mandy, you should always talk to your healthcare provider before you start to supplement, because you could be on some meds where that could have an impact as well. And then, of course, eating foods that are high in omega-3s, like fatty fishes, are a great way of getting dietary omega-3s.
Thank you. So our next question, I kind of alluded to it a little bit, but let me just see. Roughly how much protein, oh, thank you for helping this. Can you give us any tips on reading those labels on the back of packages and food? What should I be looking for? I was told to reduce sodium, but what does that actually mean in terms of what is on the label? Who wants to take that one?
Well, I can start with how do you know whether something's a good source of a nutrient or a poor source on the food label? There is a value that's called percent DV, daily value, on the back of a food label. And if something is 15% or more, then it's high in that nutrient. And if it's 5% or less, it's considered a low source. So you definitely, when you're looking at sodium, want to choose something that's much less than 15%. Because, so if you're looking at two food labels, one that's over 15% of the DV versus one that's significantly lower, such as 10% or lower, would be a good idea. And in fact, if you can find things even lower than 10%, that would be great from a sodium perspective. So I would look at that percent DV. Mandy, do you want to add to that?
Yeah, so when it's also important to look at the serving size as well. So compare the serving size to the amount you eat, because this amount tells you the size of the single serving of the numbers that were listed in the package. Then you would go down the list and look at the calories, the protein, the fat, the sodium, and calcium. You should have less of the sodium and the fat. And on the other side, there's where Diane mentioned about the percent DV that you can compare between different foods as well.
Thank you. Kalina, any tips from your end?
I don't have anything else to add. And I think Mandy pointed out that look at the serving size is very important, because I actually have families and say, oh, like, you know, it's not that bad. When you look at it, oh, they're referring to, like, you know, 2 serving size or whatever. So just be careful when you read the whole thing and read all the labels together. And also sometimes you can compare as well, you know, have different type of can, like for example, can of food or canned soup or whatever, and then just compare so that you know the nutrition value and the sodium value on each one.
Great, thank you. So the next question is around the type of protein or how protein is derived. How effective is it to move from meat-based protein to plant-based protein? And this was in particular referring to kidney transplants. Diana, do you want to start us off?
I think that moving from meat to plant-based protein is really a personal preference. Eating complete proteins are really important, and high quality proteins. There's lots of plant proteins that really are great sources of protein, like soy, for example. And so it is effective from long-term risk of cardiovascular complications like high levels of blood lipids and cholesterol. That's a common complication post-transplant in adults. And so eating a plant-based diet can help with that. But you have to keep in mind about your overall muscle health too, because if you suffered from reduced lean body mass pre-transplant, if you've been on dialysis for a long period of time, then you do need to make sure that you're eating enough of the plant-based proteins. And then there'll be concerns about electrolytes too, and electrolyte stability after transplant, but I'll leave that for Mandy to talk about as well.
So before kidney transplant, you're very likely on dialysis, and your team would probably tell you to limit the high potassium and high phosphorus foods, and a lot of the plant-based protein are quite high in potassium and phosphorus as well. But after kidney transplant, most people can go back to a regular diet, and their blood work would be checked very regularly by the transplant team. So in this case, it would be fine to include plant-based protein in your diet. And like Diana said, it's a very healthy source of protein as well, high in fiber and low saturated fat content. But some post-kidney transplant patients may develop high potassium from their medication. So in that case, the plant-based protein would need to be limited. So it's very individualized based on your blood work.
Great. Thank you. I think what I'm hearing is it's individualized, and yeah, that definitely both are options. So thank you. Our next question, roughly how much protein should one consume daily? Understandable that every patient is different with the numbers. Should we start with, from a transplant perspective, Mandy, do you want to start us off?
So like this participant mentioned, everyone's protein need is different depending on their health condition. In general, we usually recommend healthy individuals to have 1 gram of protein per kilogram of their body weight. But if you have kidney disease without dialysis, your protein need might be lower. But if you have other conditions like cirrhosis and stage liver disease, then that may, and any other condition that may lead to malnutrition, your protein need may be higher. So again, it's very individualized depending on your health condition.
That's great. I just wanted to take a pause to acknowledge we've got lots of great people that are tuning in today and sending us links to fantastic resources. So I'm sure we're going to find a way to post some of these links in our follow-up email for those that have signed up through the event, the Bright. So thank you.
So just to add to what Mandy said about the protein daily intake. So for patients with end-stage liver disease, that we usually recommend 1.5 gram of protein per day. Is that correct, like Diana?
Yes.
Yeah, and Mandy?
1.2 to 1.5.
Exactly, yeah. So because that is the, it is because people with end-stage liver disease, they tend to lose muscle, and muscle loss is a big complications from cirrhosis. So we have to make sure that these people are taking enough protein.
I agree with that wholeheartedly. Yeah. They definitely have increased protein needs.
Very individualized based on the health condition.
Yes.
Great. All right, that was a great discussion and tips. This one is a great question around weight-bearing exercise versus non-weight bearing. Is it necessary to maintain muscle mass, or is it just general exercise in combination with the right diet that's good for us? Who wants to take that one?
So I actually do think there's strong evidence to show that weight-bearing exercise is not only important for your bone health, but for your muscles. So that can be just walking, plain walking, or it could be things like resistance exercises, like with using of elastic rubber bands. But walking is really, climbing stairs are all really important to promote the muscles, to stimulate, to make new muscle cells. And so that's really important, but it's also important for your bones. And of course, you need to eat a healthy diet. Make sure you get enough calcium, vitamin D, and protein in your diet to go with that. Non-like weight-bearing exercises can be really helpful if you have joint issues. So patients maybe who are overweight or obese, who have joint issues in their hip or in their knees in particular, would benefit from also non-weight-bearing exercises in a pool, for example, and swimming and so forth are helpful. So it is individualized, but definitely weight bearing is an important exercise of activities of daily life, of walking, of resistance exercise are really important to maintaining muscle mass. And there is evidence that as a strategy to help deal with that as a rehabilitation approach in combination with making sure your protein and your vitamin D intake is optimal, that there's some evidence that that's very helpful in patients with liver disease before transplant.
Yeah, I just want to add that Diana has spoken about weight-bearing exercise is good for the bone development as well and prevent bone loss. And osteoporosis or osteopenia is very common among Asian women. So it is very important that we'll continue this weight bearing exercise. I mean, you don't necessarily have to buy any special equipment, but it's just simple walking.
Yeah.
Just continue walking and improve the muscle mass, and that will really help. Yeah.
That's fantastic. I think my background being a physiotherapist, just knowing weight bearing exercise can still be very gentle. We talk about high impact versus low impact weight bearing. So again, those with joint conditions, it's really gentle walking, exercising. And again, I think with any other conditions that you may have, you may want to consult a physiotherapist or again, your healthcare professional around what's good and what's recommended to avoid, even just climbing stairs or things like that. Yeah. So thank you. The next question. So is it normal to lose a significant amount of weight post-transplant? Shall we have Mandy start us off, and then we can...
Sure. I guess it depends. Let's say if it's liver transplant, a lot of pre-liver transplant, they are carrying a lot of fluid weight. So in that case, I would say it's normal to lose a lot of weight in terms of the water weight. But some people do lose weight because of the loss of protein during their hospital stay. They may not eat well during their hospital stay. But in the long run, because that you're on anti-rejection medication, it may stimulate your appetite as well. So in the long run, it shouldn't be normal to lose weight. But in terms of, let's say, kidney transplant or any other transplant, it is not normal to lose a lot of weight post-transplant. Usually when you feel better with a good kidney, you may tend to eat better as well. So weight loss is not usually a problem post-transplant.
Thanks, Mandy. Is there like a guide in terms of the number of pounds or the percentage or the length of time that you're losing weight that, is an indication that should be seeking some additional clinical advice?
Let's say within a month, if you lose about 5% of your body weight, then that's a significant weight loss. Then in that case, I think you should contact your healthcare team.
Okay, great. Thank you.
I'm wondering too, if you would recommend a daily weight, because for patients with ascites, with all these increased fluid in the belly, this is what we recommend our patients to weigh themselves on a daily basis, so that you can gauge based on the number and see how much water you have retained and so forth. And so if you have a scale at home, then that would help yourself to monitor the weight loss.
Yeah, I think that's a good idea to monitor your weight.
That's great. I think that's always helpful if you can keep a log. So if you do contact your health care professional, you have a bit of a log over time on what's happening and fluctuating. Thank you. All right, this is a great topic around insomnia. So there's nothing worse than not being able to sleep. So as a result, I have insomnia as a result of medications and do not want to try herbal remedies. Which foods will help me sleep? And maybe also, is there things that we should avoid eating to help us sleep? Shall we? I'm picking on Mandy quite a bit. Mandy, do you want to try that one and everyone else will join in?
I agree that not taking herbal remedies, it's a good idea because of the anti-rejection medication that you're on. It's not a good idea to take any herbal remedies before consulting your team. But in general, I would suggest taking a very light snack before sleeping because it's hard to sleep when you're on an empty stomach or when you feel hungry. And also cutting back on the caffeine later in the day. So maybe take it early in the morning or early in the afternoons because caffeine can affect sleep, your quality of sleep as well. Anything else the panelists want to add?
I just know the general advice is often to avoid lots of stimulus for your eyes. So the screen time before you go to lay down in your bed, you should stop looking at it. And that's a problem I have myself, to turn off your computer, the TV, a good 15 to 20 minutes minimum. Some people say half an hour to an hour. So, and then when you go to bed, like, go with the plan to go to sleep, so that you're not looking at all these other things. There are some things about the computer screens and your phone and whatever, in terms of your retina and the neural activity it stimulates, that might play a role in how well you sleep. But again, I'm not an expert, so that's just some general advice that we will give in clinic as well.
Mm-hmm. Yeah, I think what I can add is I'm no expert in insomnia, but again, is what Diana had said, like avoid all this stimulus before the bedtime. And also think about, I don't know whether you nap during the day, because this has happened to a lot of our patients with cirrhosis, that they cannot fall asleep at night is because they sleep during the day. Yeah. So if you could try to reverse that, like, try to stay awake during the day, and then you would hopefully fall asleep more easily at night. And also, like, I noticed that you said that insomnia is a result of my medication. So, I mean, I don't know whether it's possible or not, and just talk to your prescriber and see whether there are alternatives, and see whether any other medication that would be, less side effect on this.
Thank you, everyone. It's 1 o'clock. The time has just flown by this hour on your nutrition questions answered. I think it was just incredible. I just want to thank our panel. Thank you so much, Diana, Mandy, and Kalina, for all your input and valuable advice, and to all the viewers who had incredible input into the questions. They were very, very helpful. And again, if you log into the YouTube channel, you'll be able to see it's been tape recorded as well. And please look at our schedule events coming up, www.livingorgandonation.ca. Again, a wonderful session to celebrate our Living Donor Week 2020 and building awareness. And again, thank you to our generous supporters, Astellas Pharma Company, Kearney and Cahill Families, and the Toronto General Western Foundation for their continued supports. So thank you so much, everybody. It was a pleasure moderating. I learned a lot, and I hope the viewers did as well. So thank you. Have a great day.
Have a great day.
Yeah. Bye-bye.
Bye.
Bye.
Hi everyone, this is Christy and I'm here to guide you through a short yoga practice. We're gonna do a little bit of movement and a little bit of relaxing and hopefully incorporate a little bit of meditation in. My biggest thing for you is to just let go of any judgment you have towards yourself. If you have no experience with this practice or if you have years of experience, you're still going to benefit from moving your body and trying to relax the mind a little bit. So we're just here, do what you can, and hopefully you will get some benefit. And maybe if you don't have this as part of your practice, you will start to incorporate this practice into your daily life, because it is very beneficial, especially during this time and this we're under a lot of stress and there's a lot of uncertainty in the world. So this can be a very calming and quieting practice for both our bodies and our minds. So thanks so much for participating in Living Donor Week. I'm happy to be a part of it, and I hope that you all get to take something away and learn something new. So for this practice today, we're going to start on our backs in our Shavasana. So just really nice and relaxed, and we'll start working with the breath a little bit and then start to move. So you're going to come all the way onto your back. And just let your body start to settle. Let your feet fall away from one another, arms by your side, palms facing up or down. It's up to you. Just begin to draw your awareness into your natural breath. You're not trying to change your breath here. We're just noticing the breath. And one thing our mind does not do is shut off. So even when we're sleeping, our brain's working, and it is impossible to not think. So this practice, you're not gonna stop your mind from thinking. You're not gonna stop the thoughts from coming in. But what you can learn to do is just let them come and go, and let them not distract you, and just allow them to come and go as they please without you paying much attention to it. So we'll start that by doing an intro to meditation, and this is how I learned to meditate, and it's just by counting the breath. So in yoga, we breathe in and out through the nose, so we're gonna start from the belly and inhale, and in your head, I want you to start to count to 5. Good, and exhale, count to 5. And another thing you can do, just keep breathing through this. If you don't want to count, you can put your hand on your belly and focus on feeling your belly rise with the inhale and fall with the exhale. And now let's see if maybe you can start to extend your exhale to 6 or maybe 7 seconds. Good, and we'll start to get some movement into our body, wiggle our fingers and our toes. Begin to circle through the wrists and ankles. Rock your neck from side to side. Good, and we'll start by drawing one knee into your chest, and you can wrap one or both hands around if you wish. And just start to get some stretching in the hips, and you can follow that by your opposite knee. And if you want to rock from side to side. And we're going to make our way up to seated position. So you can crisscross the ankles and just rock and roll yourself up, or just come on up however you see fit. From here, moving into our tabletop pose. So coming onto all fours, You want your shoulders stacked over top of your wrists. Knees stacked underneath your hips. Fingertips spread nice and wide, slight micro bend in the elbows. So here you have a neutral spine. We're gonna move through 4 rounds of our cat-cow. So this is really great for the spine. It both flexes and extends the spine. So we'll start, remember, breathing in through the nose. If you can, inhale, start to tilt your pelvis towards the ceiling. Let your belly drop and lift your head. This is your cow pose. And start each movement from your hips. As you exhale, scoop your tailbone under. Begin to round out through the spine, head down last. Good. Think about moving 1 vertebrae at a time. Inhale, tilt your pelvis towards the ceiling. Let that belly drop. Exhale, tuck your tailbone, round through the spine, 1 vertebrae at a time, head down. This is your cat pose. 2 more. Just go ahead, use your own breath. Come into your cow pose. And move into your cat, nice and slow. Last round, cow. And move into your cat. Good. Bring your heels together, sink down towards your heels. You don't necessarily have to reach your heels. Stretch those arms forward and rest your head, if you wish, on the mat or the floor. This is your child's pose. Soften those shoulders, 3 breaths. Good, coming all the way up. We're gonna move into a little core exercise. So there's a lot of different ways that you can modify this for your body. So this works on core and it works on balance. So stay in your tabletop, and if you wanna sink back and just shake out the wrists, you can, especially if you're not used to bearing any weight on the wrists. Can be a little bit uncomfortable. Okay, so back to our tabletop. So we're starting on the left side. So we're gonna extend the left arm. And if this is where you get today, then be very proud and just be grateful for this. So next step, try to avoid kicking anything behind you. That right leg will come out. So we're balancing our body. We wanna ask the core to do a lot of this work. So you're gonna pull up on the belly, draw your navel towards your spine. This starts to activate the abdominal muscles. 5 breaths here. You can stay here for the 5 breaths, or we can take some movement. So you can inhale, bring your knee and elbow to touch. Exhale, extend. You can move through 4 more breaths, or you can start to pulse that back leg. This will help with the glutes. So 3 more breaths, or you can, if you're just trying to work on your balance and you feel really unstable, put your both hands down, or you can just have 1 arm out. 1 more breath. Inhale. Good. Exhale, come back to your tabletop. We're gonna sink down into a child's pose, so you can come into a different variation where you bring your knees apart if you wish. 3 breaths in child's pose. Let those shoulders be nice and soft. Good. Coming back to our tabletop, working on the other side. So this time, right arm comes out, left leg comes out. Good. So again, you can stay here, work on your balance, pull up the belly, draw navel to spine, or inhale, knee, elbow touch. Exhale, extend 4 more breaths, whatever you're doing, if you want to pulse that back leg. Or again, any combination of these activities. So you can stay stable. Again, no shame, no judgment. 2 more breaths. Last one, inhale. And exhale, bring yourself back to your tabletop. Again, we're taking child's pose. Stretching those arms forward, just let yourself melt. If you want to rest on one or left ear or right ear, you are welcome to do that. Good, so we're gonna come back to tabletop. This time we're gonna come all the way down onto our bellies. We'll do a little bit of a back bend. So this is great, especially if you spend a lot of time working at a desk where you kind of tend to be hunched over a lot during the day. This is a really good counter pose for that. So come all the way down. Your arms are bent. You want your thumbs in line with your shoulders. And the key here is to try and soften those glutes. They do have a tendency to sort of tighten up here, but I want you to try and just get them nice and soft. So you're gonna come up to your elbows. You can move your elbows further away from you if you wish, or if you're feeling any sensitivity in your spine. And this is it. We're just gonna look forward for about 20 seconds. Let those shoulders be soft, soften those glutes. And we'll give our back, the backs of our neck. So nice little stretch by just looking down. Soften those glutes. Try to soften the muscles in your face. 3 more breaths here. Good. Come all the way back down. Use your hands, press yourself back up to your tabletop. But swing your legs out to either side. We'll come onto our backs and make our way down to our backs, all the way down, nice and slow. And working a little bit more with the spine. Nice gentle twist. Knees are both bent, and just drop your knees over to the right hand side. So a gentle twist of the spine. If this feels like too much, then you can bring your knees farther away from you. If you want a little bit more twisting of the spine, you can bring your knees closer to your chest or your elbow. Shoulder wants to lift off, that's totally fine. If you can, bring your gaze over to the left side. And if both of your shoulders are able to come down onto the mat, then just start to soften them here. Your arms can really do anything, be anywhere. If this is too uncomfortable for your neck, by all means, any position that's comfortable for you. We're sitting here for about 3 more breaths. Just gonna let that spine twist, decompress. Again, counting that breath. If you find that your thoughts are just flooding back, bringing to mind one thing today that you can be grateful for. Very good. So coming out of this twist nice and slow. Bring both knees back to center. And we'll just drop them onto the left-hand side this time. Again, if that right shoulder comes off, that's totally fine. If you're able to get your gaze over towards the right shoulder, if not, again, totally fine. Hands can be anywhere comfortable. And then again, just start to come back to the breath through the nose, letting your body start to soften. Allow your tongue to fall from the roof of your mouth, helping those muscles in your jaw to relax. Very slowly starting to come out. Bring both knees back to center. And we're going to finish our practice in butterfly, reclined butterfly. So if your hips are really tight, this is really good for them. So you bring the soles of your feet together and just allow your knees to fall away from each other. So if this is too much, you can lift your bum and then place your hands underneath, palms facing down, or you can bring your feet further away from you. So making sort of a diamond shape. This actually will start to target the low back instead of the hips. Whatever is most comfortable for you here. And I want you to place your left hand on your chest and your right hand on your belly, allowing your face to start to soften all the way from the crown of your head as you exhale. Let each muscle throughout your body start to soften. Maybe starting to count your inhales and exhales, restarting that meditation practice that we started the class with. These last few moments are for you. So just give yourself permission to let that body go. Very slowly, very gently, just start to extend both legs, coming into your final posture, your Shavasana. Arms by your side, palms facing up, feet falling away. Last moment here. With gratitude, start to wiggle your fingers and your toes, bringing your awareness back into your body. Circle those wrists and ankles, rock your neck from side to side. Slowly starting to open your eyes again. We'll do one full body stretch. Inhale, reach both arms overhead, stretch your toes forward. Hold this for 5, 4, 3, 2, 1, and then sigh that out. Let your body go. Rolling over onto one side, using your arm as a pillow. And then with that free hand, pressing yourself up to your final seated position. The most comfortable position for you. It doesn't have to be cross-legged. You want your shoulders nice and soft, arms resting comfortably. And just turning your focus inwards with love, with gratitude for yourself. Thanking yourself for practicing. And we'll inhale, reach both arms overhead. Exhaling our hands down to heart center. The goodness, the light, the love inside of me honors the goodness, the light, the love inside of all of you. And namaste. Thank you so much for taking the time out to practicing with me and just being here for this week with all these amazing speakers. I hope that you all have a wonderful day, and love and blessings to you all.
Hi, everyone, and welcome to In Conversation with Psychosocial and Ethics. My name is Heather Badnock, and I'm a non-directed living liver donor, and I'll be moderating today's discussion. Really looking forward to it. Just a reminder that you can submit your questions on slido.com using the event code PM2. Also, just so you know, today's session is being recorded and it will be available on the Center for Living Organ Donation's YouTube channel. So really glad to be joined today by a fantastic panel. And just before we introduce our panelists, I'll give you a little bit of my backstory. So I originally applied to the Center for Living Donation to be a donor several years ago, was thrilled to be accepted, and I left it up to the transplant team to choose the recipient who needed it the most. So I donated 22% of my liver to a child who I've never met. I don't know who they are, and they don't know who I am. It was absolutely the best thing I have ever done, best decision I ever made, and really glad to be with you here today. So let's meet our panelists. Shall we start with Mark?
Good afternoon, everyone. My name is Mark Doucette. I'm the manager of the Department of Spiritual Care at UHN. And I guess my experience and our experience generally in spiritual care tends to be with prospective deceased donors, families of deceased donors, sometimes with the recipient or families of recipient, but certainly, generally speaking, with the deceased donor or family. And it's good to be with you today and hopefully to be able to share some of my experience and the experience of spiritual care and how that profession can be helpful through this process.
Thank you, Mark.
Thank you.
Also on the panel today, we've got Jed Gross.
Hi, my name is Jed. I am the transplant lead from our bioethics program at UHN. I'm originally from Pennsylvania. I have a law degree and I moved here about 3.5 years ago. Where I enter the picture is generally when the transplant team is grappling with what is the best way to proceed. However, we're available to patients and family members as well. You can just call UHN and ask to speak with a bioethicist.
That's great. Thanks so much, Jed. And also rounding out the panel today is Sonali.
Hi, my name is Sonali Pandarkar. I'm the social worker for the liver transplant team on the recipient side. I've been with the program for 13 years now, so I've seen a lot of recipients come through our program. I work primarily with the patients and their families, and sometimes the family members are their donors. So I do get to see a little bit of that in the early stages. And I'm going to do my best today to speak on behalf of the liver donor social worker as well. So bear with me if I don't have all the details, but I will try my best to answer any questions you may have from that perspective. I'm looking forward to today.
Thank you so much to all of you. We thought that we would start with a little bit of information leveling, knowing that folks who have joined us today may not know the program in detail. So one of the things we wanted to start with, because we know we're going to dive into it, is a little bit about how the screening process works. And I can speak to what that screening process looks like for someone who is a prospective liver donor. So anyone who's interested in being a liver donor applies to UHN, and that application is screened by a nurse. It's an 11-page health history. It offers a lot of detail. And of those who apply, if their health looks, at least from the paper copy, suitable, then they're invited to in-person screening, which involves a number of steps from blood test to chest x-ray, MRI, CT, social work, psychiatry, meetings with the transplant team. It is incredibly thorough, and the safety of the donor is incredibly important. If a person is accepted to be a donor, and for liver donor applicants, it's about 1 in 8. If you're accepted to be a donor, which for me left me in a hallway crying of joy to be accepted to be a donor, then you go on to have your surgery scheduled. You have a wonderful nap while the transplant team involves you in saving a life. You wake up and are waited on in the hospital for 5 or 6 days. Your liver is already growing back at that point, and we go home and recover from there. That's a quick snapshot of what it entails to go through the process to be a liver donor. And we wanted to hand it over to Jed to tell us a little bit about the difference between what is, when we use these terms, a directed donor versus a non-directed donor. What are those?
Sure. A directed donor is someone who is donating their kidney or part of their liver to a specific individual. They usually have an existing relationship like a family member, but it may also be possible to anonymously donate to someone who has made a public appeal. A non-directed donor is someone who essentially says, I want my donation to go to whoever is the best match. Organ donation after death is generally non-directed. It's also possible to be a living non-directed donor.
That's perfect. Thank you, Jed. And Sonali, can you give us some insight into the process for recipients?
Sure. So the recipient process is, the medical evaluation is very similar to what the donors go through. The only difference is they go through it first. So we have the entire medical evaluation for liver and kidney recipients, any organ recipient, to go first, which includes all of those, ultrasounds, CT scans, surgical consults, either a nephrologist, kidney specialist, or a hepatologist that's a liver specialist. Breathing tests, every part of your body is looked at, and social work is part of the end of the evaluation. And we really just look and give a snapshot, or get a snapshot of who you are, what resources you need to plan for, the education piece, providing some support around this big ordeal. And just make sure that everybody is in the right frame of mind and in the right place to go forward with transplant. And then we get to meet together to make a decision about going forward for transplant. And then that's the point where the donors get to start their evaluation. So we always start the recipient evaluation first.
It sounds so thorough. Like there's so much that happens behind the scenes.
It's a well-oiled machine.
Now, Jed, sometimes things come up along the way. So, and sometimes these are ethical concerns. And so when in the transplant process does ethics get called in, and what sorts of issues are coming up?
We generally get called to make to guide discussions of forward-looking policies, or when a situation arises that doesn't quite fit within the normal procedures that we anticipate. So let's say someone wanted to donate their organs to patients in their city, but it's not possible, or the transplant program has concerns about the fairness of that arrangement and the precedent it would set. I might receive a consult to figure out what we can do and guide that discussion. Specifically with reference to living donation, the situations in which ethics is likely to be engaged would be when we have a donor with a complex medical history or social situation. Perhaps someone in need of a transplant has a relative overseas who's interested in donating, or when we're innovating and thinking about an unusual arrangement. We had recently a paired liver exchange involving 4 individuals. So there was an anonymous non-directed donor pair who were incompatible, so they couldn't do a direct transplant, and then an unmatched individual who benefited from a transplant. One of the great things about being at a place that has a deep and wide team is that we can figure out how to do these things in the best way possible.
It's so interesting because I don't think, we think about medical settings and we think about the range of teams that are on call in a medical setting that respond, sometimes quickly to changing situations. And I don't think we fully appreciated until we started talking to you that in fact, ethics is very much on call as well.
We're not quite embedded in the transplant program, but we're always on call and we're welcome and work together closely. So hopefully these calls are not coming in the middle of the night with that sense of urgency, because with enough forethought, we can usually work together as a team and avoid the midnight crunch.
Yeah, and there's so much that comes into a transplant decision and support that's needed along the way. And Mark, there's a role for spiritual care in that. There's a role for spiritual care in transplant. How would you describe what that role looks like, Mark? Mark, you're on mute.
Thank you. Yeah, Heather, normally we are introduced as a service, unfortunately, often at a time of crisis or trauma, in which families are looking at the potential of a deceased donor and the opportunity question as to organ donation. And so the events that often lead up to that are traumatic, they're recent. So there is, families are still in a state of shock, processing a lot, and then being introduced to the idea of possibly using their loved one, being able to use to retrieve the organs. And so I think there, some of it, and certainly social work would share in this as well, as supporting families through that decision making. From a spiritual care point of view, it can often be, if they are adherents to particular faith tenets, what would the religious body say about it? In those cases, our best case is if we can connect them with somebody, a religious leader. Even if I might know the answer, it just has more value coming from of the same religious background. There's that security that this is correct information. But from a spiritual point, it's also what helps families make sense and meaning out of what is often a very traumatic event in their lives. And it's often a way to bring something, as trite as the expression is, something positive out of a very negative experience.
So in this really difficult place and time, there is support for families as they come to terms with what has happened, but also to give some sort of meaning to the death that they're facing of their loved one.
Most definitely. And in the best case scenario, we would have already been involved, because there are practitioners within the different clinical programs and certainly within ICUs, the critical care program. So hopefully there's some relationship already with the family before this gets introduced as well. That helps because there's a trust level there, and families maybe feel a little bit more open. We've had an opportunity maybe to hear some of what are the families or patients' values, how they've lived their lives, what's important to them, and all that goes into the decision making. We are not there to guide the decision. We are there to support them in whatever decision they come to.
That support is so important, and there's so many moving pieces, aren't there, in this whole process. And when we think about some of the different processes that are coming into play, and I think about the living donation side of things, we know that there's some separation that exists there, right? When we, Jed and Sonali, so there are different teams that work with the living donor when they apply versus the recipient. And so even though they're moving towards the same sort of transplant goal, why is it that the living donor team is separate from the recipient team?
Sure. When transplant programs organize living donor transplants, we want to establish a relationship of trust with both the donor and the recipient. You need to be able to share sensitive medical information with us And if either person has reservations about proceeding, we need to know that. In order to avoid conflicts of commitment, where one practitioner feels pulled by their dedication to more than one patient, it's best to have dedicated teams working with the donors and recipients respectively.
It's really good to know.
I'd probably add too that we have to remember that donors themselves are, when they're coming forward as potential donors, they are also patients of our program, and we want to ensure that everybody's confidentiality is also maintained. So we don't ever want there to be a potential of an overlap outside of, once that match is made, making sure that it's a fit for each other, but really treating everybody as their own individual and not having that overlap. Which then Jen mentioned, we don't want to compromise the importance of one over the other because of conflicting values.
That makes so much sense. Like, as a donor, I always felt like I had a safe space where I could talk to the team, where, there was a nurse that was dedicated to me who, as far as I know, wasn't engaged with the recipient side of things. And so I felt like I could ask whatever I had to ask, and that I knew that they were looking out for me as a donor. Like, I really felt like well cared for. And on the recipient side of things, Sonali, what would you say are some of the most common questions that come up?
From, like, in general, about, are you asking in terms of just
like as they move towards transplant, there must be so much that goes on that you see as a social worker, and I know you have many, many years of experience, and so, but if you had to highlight some of the common questions that come up.
I think everybody wants to know when they're going to feel better. How long is it going to take until I'm back to normal? What is it going to be back to normal the way it was before? Is there a new normal? A lot of people say, how much is this going to cost me? And so we really talk about what the resources are, what is available through OHIP, and what may be an out-of-pocket cost. I think, what's it going to be like after? Am I going to get my life back? Am I going to get back all the things that I've lost through the illness process? Because then what's the point if I'm not going to recover, and if I'm not going to be okay?
What do recipients feel like? I'm really touched by that. What do recipients feel like they lose in the process of being so sick?
Well, so just even now during COVID, some of the things I'm hearing about are my patients who are isolating from their grandchildren for fear of infection. And so what a loss that can be. But I think even before COVID, we know that, with kidney, it's dialysis 3 times a week or more. With liver disease, the symptom burden is so high, and just that inability to participate in activities of daily living as a personal care measure, but also just social activities, and being able to comfortably go to a family wedding or to a family function without, having the symptom burden impact that is such a huge loss. And it varies. Obviously, some have more symptoms than others, but there is a very big toll that these illnesses take on our patients and their families, because sometimes the families need to stay home and be the caregivers, so they too are missing out. So there can be a long process of missed opportunities and missed experiences leading up to transplant. And so there's just a lot of optimism and hope about what will be gained or what will be taken back after transplant.
Yeah, Mark.
When you talk, Heather, about the questions that sometimes comes up with donors or the recipient, is often a profoundly spiritual one, because who am I if I have this organ in me that's come from another person? What does that do to the questions are, how do I incorporate this into a sense of my being, my personhood, the person I am? So those are profound. There's a psychological component to that, but there's also a profound spiritual element to that around the personhood I understand myself to be. And so there's a change there. Donors will often talk about, or the recipients, often talk about what's that like for them to continue to live. and to know that they're living as the result of the death of someone else. And that juxtaposition of both being relieved, happy, gratitude, but also tending sometimes to a little bit sense of guilt because of the death of someone, and recognizing that. And it's often just being able to talk that out.
How do people process that, knowing that in some cases, you know, if they don't have a living donor, that it's certainly not a death that they have caused in any way, shape, or form, but that there is a death that allows them to live?
And that can vary. And I mean, it certainly does vary. So from my experience, just something I kind of remember is one that helps us a profound sense of gratitude. Gratitude for the particular person, even though they don't know it, who the person is, but they can still kind of direct that energy, their thoughts to that. For others, it's kind of feeling that they are able in some way to continue the life of the person. And certainly donor families will say that, like deceased donor families will say, this allows, you know, the life of this person to continue in some form.
So there's, I hear sometimes recipients talk about an honoring, like they honor the life in some way that has contributed to theirs.
Yes.
Yes. Sonali.
I just wanted to add the other piece that I often talk to families about who are struggling with how to honor this unknown deceased donor is really just care for the organ, to understand the gift that another family or the loss that another family has had and the gift that they've given, and to do your very best to honor that by taking care of the organ in the best way that you can, and not letting that gift go to waste.
Yeah, that makes such good sense. Yeah, it's really touching when sometimes we see online the things that they're doing to honor their unknown donor. It's really special. In terms of some of the most frequently asked questions that that living donors ask, and we see these come up in a lot of there's online support groups, discussion groups. It happens on Twitter, it happens on Facebook, all across the board. And I think one of the top questions that we hear is about the recovery process. You know, the screening process is really well spelled out. People understand that. People understand what happens during the surgery. The teams are so incredibly, you know, really good at explaining what's going to happen, but the recovery feels like such an unknown for donors, and it is so different across donors. And so we know that some people may have complications that include, you know, nausea or pain, or, you know, sometimes, you know, other things that keep them in hospital for longer. Some of us kind of spring out and go home. And so it really varies. And, but they're fascinated always to know how quickly it starts regenerating. And I know that Dr. Grant is retired, but I often, you know, reference, and I think people are fascinated to know that the liver starts regenerating on day 2 after surgery. And it's at full function, if I'm remembering correctly. Obviously, I'm not a doctor, but full function by day 10. And then an MRI about the 3rd month confirms that it's actually regrown. But that's what we hear the most often is, what's my recovery going to be like? And so we try to answer that as best we can. Now, I feel like you've each touched on some different relationship dynamics. And so, you know, when we see different donor recipient dynamics, and donors will tell you that the desire to donate can be powerful. We also hear about recipients that hesitate to accept the donation, you know, living donation from a family member. You know, we hear about a dad maybe hesitant to receive part of his daughter liver. And so when you talk about, you know, relationships in transplant, what are some of the things that come to mind for you? And if we start with Jed, you know, what comes to mind in terms of relationships on the living donation side of things?
Well, there's no one right kind of relationship between a living donor and recipient. Initially, transplant really got off the ground with kidney transplants between identical twins, because at the time that was what the technological capabilities permitted. But we've seen people donate to family, to emotionally related individuals, and to whoever needs it most. In some cases, people donate out of a sense of duty almost, that they want to give back. In other cases, people say that they're donating because they just want to do it and want to know that they helped someone. We don't try to tell people what is the right or wrong reason to donate, as long as it's a free choice. That's one of the wonderful things about being in a system that recognizes the diversity of human relationships.
That's really interesting. And Mark, you touched on, some of the notion of gratitude and needing someone, in some cases someone needs to pass for the recipient to live. And has this come up during COVID as well? Has this shifted or been different in any way?
One of the uniquenesses, Heather, around through this time of COVID has been that a lot of the situations, circumstances that bring about organ donation after death have been scaled down. So with a lockdown, we haven't, there hasn't been the same mobility, we haven't been socializing, we haven't been traveling. And so there's in some ways been less organ donor available. And so one of the conversations one of my team had with a prospective recipient was this pull within them, because they were on a list, a waiting list. The time gets longer because less organs, and then an organ became available, and then the person talking about feeling guilty that they were almost wishing the demise of someone. I mean, they weren't directly, but that emotional response, right? And so how do you come to terms with that, from a spiritual perspective? There is a sense of gratitude, there's a sense of sadness. So maybe there's both the gratitude and the grieving that happen. And some people they really do sense that grief. They also know that somewhere there's a family involved that's tremendously grieving because it's been a traumatic event. And so it's about holding both of those from a spiritual perspective and allowing both to be expressed and maybe even facilitated, ritualized, symbolized.
It's such a range of emotions that maybe people who haven't been part of the transplant process may not appreciate, that receiving an organ is not just a celebration, that it's life-saving, but at the same time, there is such a range of emotions that a recipient experiences in that moment, but possibly forever as they come to terms with what they've experienced. And Sonali, you see in all your years as a social worker a range of relationships. And as we were preparing for this panel, you talked about it being, in a way, some of your favorite conversations. Tell us about that.
Well, I see recipients and their families before living donation is really a reality. Some families will have already come with a plan in place and who's the donor, and others have had conversations within their families, but they haven't come to terms with anything. So, I mean, relationships are complex, and they're loving, they're love, hate, all those kinds of things. And I just had a wonderful opportunity of being part of so many family discussions around this. So Heather, you alluded to, the parent who doesn't want their child to donate. And, I've had lots of conversations with both sides, the parents and the children, and the being able to play the devil's advocate a little bit. And my role is never to convince anybody to do anything, but just to support that thought process. And, the parent who doesn't want their child to donate maybe is not thinking about the consequence to the child if they're not able to donate. And for some of our patients, unfortunately, they won't make it to transplant without a living donor. And so that ability for a child to give their parent life so their parent can be around for their, the rest of the milestones. I've spoken to spouses when there's little children involved and the one wants to donate to the other, but what are the considerations? And we'll never say no to a donor, but there's things that need to be considered and thought about, that in the heat of the moment and in the passion, if you will, of wanting to help your loved one, sometimes you don't always think about it. And then, of course, there's also the not so positive dynamics where there's almost an expectation that a family member will step up to donate. And that doesn't happen because of long-standing issues. As I said, family dynamics are complex. And then the guilt sometimes of a potential donor who really wants to donate, but either through their own health issues or fears of surgery, all sorts of different things, aren't able to. And, working through some of that grief on top of the potential grief of a parent being sick. And there's so many layers and so much complexity, but it's really is such an honor to be part of those conversations and to, again, not guide or make any decisions, but just to support people through their different emotions and their different thought processes. So it's really a fascinating place to be and an amazing support to be able to offer.
Yeah, what a range of things that people experience, and there's thankfully these supports available to help them through, and things. We know also that these processes and the supports available and things that happen on the transplant side change over time. I had the pleasure last month of giving blood with a pretty special guy and having a long chat with Kevin Gosling. And he was the first non-directed liver donor in Canada, maybe also in North America. And so he approached UHN and asked to give part of his liver without a recipient in mind. And this was in 2004. And the team was, he says, open to the conversation, but it certainly wasn't, there wasn't a process in place, right? And so his application to give led to a lot of discussions. It took 16 months, as I recall, as he describes it. And he was so enthusiastic, and it was his also continued diligence and enthusiasm that made it really possible. Plus the team was so open to it. UHN is so innovative in so many ways, thankfully. And so he was ultimately accepted. He knows very little about his recipient. He does know that he saved the life of a 10-year-old boy. But he was, at that time doing something really groundbreaking. And he was, non-directed donor number 1. And what's kind of neat is that UHN keeps track of non-directed donor, liver donor numbers. And so we each actually know which number we are. So like I'm non-directed liver donor number 55. And as far as we know, the most recent one to give was number 71, if not 72. And I had the pleasure of mentoring that person. And so what was hotly debated in 2004 is now quite common and has been done 71 times. So and is done really in many cities now around the world. So Jed, thinking about the evolution, and how these things evolve over time, what is being discussed in transplant these days? What is making its way from maybe not so common to more common, or what doesn't have a process that's receiving a process?
Yeah, thinking about the stories that Sonali and Mark and you shared, there's a theoretical aspect to this job and a human one. What's really rewarding is when we work on something that involves wide-ranging discussion and careful planning, like that paired exchange, and then we see a good outcome for the patients. What gives me hope, short of being able to grow organs in a lab, is the potential for further innovations like advanced donation, where someone donates now with the understanding that should their loved one need an organ in the future, they would have access at the end of a chain, for example, of donations. this is the kind of thing that potentially can enable more people to benefit from transplant, but it needs to be done thoughtfully to ensure that we don't have a bottleneck in the system. For example, kind of the equivalent of people having frequent flyer miles that aren't actually good on a flight. Hopeful that we can find a way to expand transplantation through that type of creativity.
So how, I mean, there's different possible ways that this could work. Like I hear about sort of ticket systems or voucher systems. So what are some of the possible models here?
I think one of the possible models is that someone would donate now as a living donor who perhaps anticipates that, say, their grandchild may need a transplant. There's nothing wrong with that as a motivation, just like you can donate directly to a family member. And then they would receive a non-transferable voucher effectively, so that later on, if that individual or a member of their immediate family needs a transplant, let's say a kidney, they might be placed at the end of one of these kidney chains that starts with a current non-directed donor and therefore produces one net kidney in the system. What we want to make sure is that we're not disadvantaging people who are already, in some sense, disadvantaged. So one of the things that has been discussed where this concern has been particularly salient is the idea of allowing relatives of living donors to tap into the deceased donor pool. The thinking there is if you have someone who's interested in living donation, but they're not a match, maybe the system should take that organ, so to speak, in exchange for giving the recipient priority access to a matching deceased donor organ. The danger is that some patients who really do not have the social network or for other reasons do not have access or good access to living donation are also waiting for a deceased donor organ, and we want to make sure that everything we're doing is consistent with the principles of fairness and allocation based on medical need.
It's so interesting to hear like the considerations that come into this in terms of like the benefit, but fairness, but the recognition that there aren't enough organs to go around. So how do we make this system work? So maybe in a year's time, we're going to have this conversation again, and you're going to give us a really neat update on, because these are conversations that are happening at UHN, but also around the world, right?
That's right, and I would be happy to rejoin in a year and provide an update.
We're going to shift to questions and answers because there's really thoughtful questions that have been submitted, and we're really looking forward to talking about them. But also, I really would love to hear from you. You know, you work so hard and you're clearly so dedicated to everything that you do. And what gives you hope when you think about transplant? So as you think about, the favorite part of your job or something that makes you smile and sometimes it's dark times, but what is it that keeps you going and gives you hope? And I'm going to ask Mark first.
Thanks, Heather. I'm just going to rephrase it a bit because I get the essence of what you're saying, but it's a little bit, when you hear my answer, it would feel awkward to talk about it as being what brings you, put a smile on your face or joy, but it's more about meaning and fulfillment. So for me, it comes from being invited into people's lives at the most vulnerable, traumatic, difficult times, and being given that honor of being invited in to walk with them through what is a horrible experience. And it doesn't always turn out, I mean, in this case, there's a positive and also a negative. So it's not about always happy endings. But it really is that, in spiritual terms, walking through very sacred spaces with people and being honored with that.
I appreciate that reframing. That's very well said. Yeah. How about you, Sonali?
I echo what Mark said. I think it is about being invited into these families and into these stories and into these lives. I actually, there are days that I have a lot of fun with the people that I meet. We talk about places they've traveled. We've talked about books that they've read, these amazing experiences that they've had that have nothing to do with their liver or kidney disease or their need for a transplant or their hope for a transplant, just the amazing lives that they've lived. And it's fascinating. I mean, there's amazing and interesting people in the world, and it's really quite an honor to sit with them and to hear some of those experiences and to see, family dynamics, the number of family jokes that I get invited into just by nature of our conversations. And it's really lovely. Like it makes you see how much hope and positivity and optimism there is in the world, even in the face of such a huge endeavor that's coming. And I think, the value for me in terms of my work is just helping people come to terms and feel ready and prepared and supported through this process, and that there are people who are listening to them, people who don't just view them as a disease, but are viewing them as people and families with feelings and lives and something more than just what their diagnosis is. And so that, I think, has been, for me, what's kept me with transplant for so long and kept me with the liver team for so long. It's just every day is new and exciting and fulfilling.
It's such a good point that the disease becomes such a focus in their life, and yet their life is so much more than that. They still have, children or grandchildren or spouses and hobbies and interests, and the disease is not, it is an element of who they are, and it becomes increasingly overriding probably as they get closer to needing that transplant, but they are so much more than that.
Yeah.
Yeah. How about you, Jed?
So much of my participation in these discussions is a little abstract as we try to figure out the best infrastructure, and that can be intellectually engrossing, but it's also very rewarding to see how that works when it plays out well. That could mean an individual who's exploring living donation saying, you know what, I don't think this is right for me at this moment. I want to put this on pause. It could also be someone who donated and says, this was the best decision of my life. Now my spouse and I can travel together. But seeing those outcomes really enables me to connect my work with the human story.
That's really remarkable. Yeah. Now, we have a number of questions that have come in advance, and I think that Courtney, if I'm not mistaken, is going to maybe walk us through which ones we're going to go through. Here we go. So see them on the screen. All right, so the first one, okay, so over to Courtney, I think.
Sure, yeah, thank you, Heather. So the first question we have here is, what happens when someone dies in hospital? Who talks to the family about organ donation? Is spiritual care involved? Oh, Mark, I think you might be on mute.
Sorry about that. So I guess
No worries.
I can answer that one. Certainly spiritual care is involved. We are involved in most deaths that take place in the hospital. Often, in best case scenarios, we're involved prior to that, especially if there's an assigned spiritual care practitioner within the clinical program. That person will have met the family and the patient. We are not the ones that raise the question or option for organ donation, because we want to be able to journey and accompany families through whatever decision they will make. And so we don't want to be seen as coming from any particular standpoint or view. So normally it's the clinical team or the organ donation coordinator that would begin that conversation. And we are there to help families process through the questions that come up for them, their values, and the values of the patient as well.
Thank you, Mark. Next question here. What does the social work assessment cover? What factors would preclude a recipient or living donor candidate from moving forward?
I guess that's me. So from a recipient side, we really like to get a picture of who we're working with. So your family, your your day-to-day life, what you feel is important to you. We do an assessment on your financial situation, not to make a decision about going forward or not, but to provide some information and support and resources around what other resources you may be eligible for, drug coverage. We do a substance use and mental health assessment. We talk about motivation for transplant. If you've got any fears or worries, trying to help you feel comfortable with the decision. We certainly in my assessments, I do a lot of education around what to expect sort of from the time that you're listed while you're waiting for transplant, the call for transplant, what happens after, as I said, resources, and the living donor social work assessment does the same. When we talk about what would preclude someone from going ahead with transplant, every individual is different, and there's different scenarios that would lead to somebody not being able to go forward. In my experience, most things can be overcome. It just may take a little bit of time to get somebody to the point where they are ready for transplant. In some cases, there's medical issues that's primarily what happens. The medical issues stop you as a recipient or a living donor. But yeah, as I said, most of the time, things from a social work perspective that may preclude someone from going forward is more about a delay rather than fully stating somebody isn't suitable. Social support is a big one, though. We do know that our recipients and our donors need to have support for the most optimal outcome post-transplant. And so that is something that we focus on and we put a lot of weight on. But again, we work through some options and to see what could work.
Thanks, Sonali. So this question is from Len. Jed, I think this one will probably be for you. I know it's complicated, but has there been any further discussion on the possibility of exchanging more than one letter between non-directed living donors and recipients?
Yeah, just as background, one of the things that we think about is what the interactions between anonymous donors and recipients would ideally look like. Transplant programs across North America have taken a wide variety of approaches to facilitating communications between living donors and recipients post-transplant, ranging from maintaining almost complete anonymity if it's an anonymous, non-directed donation, to making introductions if the individuals are interested. UHN generally enables one letter to be exchanged, which reflects a philosophy of maintaining clean lines between anonymous, non-directed donation and other kinds of donation like directed donation, where you may have found someone online who is in need of an organ. However, we've received some feedback that this structure can create stress for participants in the transplant as they decide what they want to say in this letter or note and when. So we've initiated a process this fall of exploring the possibility of facilitating additional communication and what implications that would have at all stages of the transplant process. For example, we're thinking about, would that in any way affect how we assess people who present as potential donors? I'm cautiously optimistic that when the key stakeholders come together and think this through aloud, we can reach a consensus.
I think that's really helpful. As a non-directed donor, I can, this is certainly a discussion that comes up amongst other directed donors, and we all feel like for 100%, this is a gift freely given. We were honored to be able to give this gift, and we have no expectation of anything in return. This is their piece of liver now, and I hope that they're doing amazing. And I know that one of the things that we struggle with is with the one-letter rule is, if I write now, I gave to a child, I'm writing to the parents, and if the child has questions later, how do they get closure on that, or how do they get answers that they might be looking for, but fully respecting the anonymity, no expectation to meet. And I have to say that as a non-directed donor, I am really, really appreciative of how receptive the center has been to this question. So when we started non-directed donors, Len and I and others started saying, we're not sure the one-letter rule works for us. I really appreciate how receptive Jed has been and the Center for Living Donation to kind of reopen the conversation and explore with us. So thank you for that.
It's a deliberative process, but we hear you.
Yeah, you do, and I appreciate that.
Okay, thank you. I applied to be a living donor and completed most of the testing, then was eliminated due to a medical issue. I was devastated. Are there supports available to help me deal with this loss? Mark or Sonali, either of you want to take this question?
I'm happy to field it, Mark. If
Sure, okay, Sonali. Yeah, that's fine.
Support. Maybe I'll kind of speak in a more global sense around support with transplant, because we do have some levels of support through the assessment process, but what we have, I think, is not always sufficient to cover all the needs of our patient population of recipients and donors. And I think we have some work to do in terms of being able to best meet the needs. So the yes and no answer to that question is a bit more difficult. There's probably some supports in the very initial phase of being turned down, but long term it's something that we're working on. We do have different avenues for support, but we're the Center for Living Donation, the Global Transplant Program. We are looking at ways to amp up our support resources for patients and their families. But it's still a big work in progress.
Wonderful. Mark, anything you want to add?
No, I think that Sonali's covered it well. Yes.
All right. Okay, the profound gratitude.
Can I put a plug in, actually?
Pardon me?
Can I put a plug in for one of our resources?
Absolutely.
So I should say we do have a really fantastic resource that was done internally by one of our mental health nurses, and it's called Coping with a Transplant. It is probably more recipient heavy than donor heavy, but it is a really great resource on sort of, what are normal feelings, what maybe aren't normal feelings, where to go for help. It's a really good resource that's transplant specific, which is very difficult to find. And of course, UHN has done it, so we're very proud of that. But I think it's a good starting point to use as a review, and then to seek out some additional support if what you read in there isn't enough.
Thanks. That is a really great resource. Thanks for sharing that. Next question. The profound gratitude of being a living organ recipient is overwhelming. It is difficult to absorb the magnitude of this gift. Is this a normal feeling?
I can start a response to that, and Sonali also, or Jen, might have additional points. I guess on a theoretical and mental level, I can appreciate the overwhelming sense it is, but I have to admit, not having been there, I can't grasp the depth of the emotional and psychological profound gratitude that is. Just a couple of reflections. It's interesting that often gratitude is something that we strive for. A lot of mindfulness now is around learning to be grateful, to be able to have a sense of gratitude in our life is supportive and builds resilience. So it's interesting to hear gratitude can also be a burden, or trying to that sense of gratitude. Two other observations. One is that I don't know if feelings are really normal. We have them. And if you are feeling that, then that's what your experience is, and to work with that experience. And maybe the best way to handle it, just as one option I would offer, is the best way to deal with gratitude is to express it. And so maybe it is to, on a yearly basis, to do some, and I'm a big ritual person, to do some ritual of gratitude for this. that also might kind of take care of, absorb, express that sense of overwhelmingness.
Thank you. That's great advice. Anything you wanted to add on, Sonali?
I was just going to say my gut reaction to that question is I think it is a normal feeling. It's a huge gift to receive. I mean, it's a life and death gift. And I think it's absolutely normal to feel overwhelmed. But like Mark, I've not been there, so I can't speak specifically to the feeling, but I think it is a big give and a big gift that somebody has given. And I think it's heartwarming that it's a question that's being asked, because it means that somebody is thinking about this gift in a very meaningful way.
Absolutely.
If I could add from the donor side, we want to give that gift, and we hear from recipients sometimes that they are hesitant to accept it, or they feel like it's this huge gift. But every living donor that I ever talk to wants to give so badly and is thrilled when we get accepted, and uses the word excited when they are talking about surgery, which sounds bizarre maybe, but the donors aren't looking for the gratitude. We were honored to be able to do it, and it doesn't take away from what the recipient feels, but it was a gift that we wanted to give.
Thanks, Heather. That's super valuable. Okay, so I think we're coming to an end here, but let's just do 2 more questions. Let's start with this one from Jed, or for Jed. In some countries, you can buy or sell organs. Is this illegal in Canada?
There's a quick answer to that. The Trillium Gift of Life Network Act, which set up Ontario's organ sharing infrastructure, broadly prohibits buying, selling, or dealing in human tissue for therapeutic purposes such as transplant. Additionally, we would admonish patients against traveling abroad to obtain a transplant in what may be medically risky and ethically problematic circumstances.
Great, thank you, Jed. We just got a comment in response to what Heather said, and this person wholeheartedly agrees with you. As a donor, we're honored and so pleased to do this. Thanks for sharing that. So last question here. If a person has mental health issues, can they still get a transplant, or can they still be a donor? Sonali?
That's a bit of a loaded question, but I think I've said this before, every recipient and donor is assessed as an individual, and that includes their physical and mental health. So each situation does need to be looked at on a case-by-case basis. The simple answer is that a mental health issue does not categorically preclude you from going forward with transplant or from being a donor. But ultimately, we want to make sure that whether you are a recipient or a donor, you are safe to go forward with transplant at that time. So I think stable mental illness and having the right supports, and just feeling like this is a safe decision and a comfortable decision for you is paramount. The actual diagnosis may or may not impact, depending on how medications may interfere, how the surgery may interfere. But at least from a psychosocial perspective, we're looking at safety. And that's where we'll look at the mental health issue. So it's not a clear-cut yes or no. It's case by case.
I would just second that from an ethical perspective, that when someone is deciding to donate, we want this to be a free and informed decision, and we have to be comfortable that the transplant makes sense from a risk-benefit perspective. But we want to make sure that we're not acting based on unfounded prejudices. We have to look at each individual case and ask, is this a stable condition? Is it something where the patient is likely to be able to withstand the stresses associated with transplantation, whether it is a mental health diagnosis or any other diagnosis in their chart?
Great, thank you. So thank you to everyone who submitted questions. We will answer and respond to the questions in the Slido link, so stay tuned there to get your answers. We'll also post them on our social media channels as well. Heather?
Yes, thank you. Thank you so much to everybody who submitted questions, to everyone who joined us today, to our panelists for sharing your expertise and your very thoughtful answers. There are so many layers to the transplant process and so much care involved from the ethics and the psychosocial and the spiritual perspective. So thank you to all of you. Reminder to those of us who have joined to check out tomorrow's afternoon sessions. So tomorrow we've got In Conversation with Donors and Recipients, and that's moderated by a live donor kidney transplant recipient, Joanne Kearney and Dr. Joe Kim. And finally, we want to mention that we are exceptionally grateful for the generosity of our founding supporters. So that's Astellas Pharma Company and the Kearney and Cahill families. And thank you also to the Toronto General and Western Hospital Foundation for their continued support. Thank you, everyone, for joining us today and for your questions and for participating. And we look forward to seeing you soon.